Hello, good evening, everyone. Good evening, everyone. Can you hear me clearly? Hi, good evening, Angelica. Good evening, Arlene, Giovanni, Arist. Jivelin, Katie. Good evening, everyone. So today we are discussing respiratory system naman. So yesterday we talked about the blood and its components. So today we are discussing the respiratory system. Okay, so again, good evening, everyone. So with the respiratory system, let's begin with the quick anatomy and physiology. So by reviewing what are the important parts of the respiratory tract. So we have the upper versus the lower respiratory tract. So with the beginning of the upper respiratory tract, we have the nose. So the nose, this is the legal entry point of air. So when this term itself, legal entry point, meaning normal inhalation. So when we breathe in normally, it is via the nose. Diba? With normal breathing, we breathe in the nose and then we exhale through the mouth. So that is a normal breathing. So this is the legal entry point of air where air is usually humidified, warmed, and filtered. Down to the pharynx. So the pharynx is the passageway of both food and air. So pharynx is both connected into GI tract in the respiratory tract. And before we reach the larynx, there's an opening or there's a flap above the larynx, which we call epiglottis. So epiglottis covers the larynx so that the food that we eat will not go down into our respiratory tract. So because as mentioned, the pharynx is both connected into the respiratory in GI tract. So before air reaches the larynx, so whenever we swallow, whenever we eat, so it is expected epiglottis to be closed so that the food we do eat will not go into our respiratory tract. So down the larynx, this is also called as the voice box. Okay, so this is our voice box. So those are components of the upper respiratory tract. For the lower respiratory tract, it begins with the trachea. So the trachea, this is our windpipe. So that is usually should be at the midline. And also, this branches into two, which are the bronchi that enters the left and right lungs and branches into smaller ones inside, which are the bronchioles. And at the end of these bronchioles, we have what we call the alveoli. The alveoli, these are the tiny air sacs wherein gas exchange occurs. Okay, so those are the important components of the upper versus the lower respiratory tract. So we have the nose, pharynx, epiglottis, and larynx for upper, trachea, bronchi, lungs, bronchioles, and alveoli for the lower respiratory tract. So what would be generally the function of the respiratory system? So I summarize it with the mnemonic RESPI. Letter R, so rendering oxygen for metabolism in the tissue, for entry of oxygen into our body and elimination of carbon dioxide. So we inhale an oxygen and then we move out carbon dioxide. So next, for the sense of smell, okay, so our nose is part of the respiratory system. So through the nose, we breathe in at the same time. This is for our sense of smell. So speech. So part of our respiratory system is the larynx for voice production. And we have letter P, promotion of acid-base balances. So we have two buffer system in our body. We have the lungs and we have the kidneys. So later on, we'll be talking about ABG interpretation. So those two systems are the ones that promote acid-base balances. We have the lungs and we have the kidney. So those are the two organs involved. And lastly, respiratory system influences body water level and heat balance as well. Because when we breathe, we are actually losing fluid as well. So about a cup of fluid is lost with normal breathing. So imagine if you're breathing faster than usual, so you could lose so much fluid as well. Okay, so with hyperventilation, for example, you could be losing more fluid than usual. So that's why respiratory system could be involved with water balance as well. So these are the function of the respiratory system. And what are the common assessment data we do for the respiratory system? So first and foremost, we have the breath sounds, right? We have the normal versus the abnormal breath sounds. So with the normal breath sound, so normal breath sound that is heard over the trachea, so this area. So when we auscultate over the trachea, we expect hollow tubular sound, which is your bronchial breath sound. Okay, so bronchial. So that is heard over the trachea. And down into the bronchi, we expect bronchovesicular. And lastly, all throughout the lung field, we call it as the vesicular. So the soft, low pitch sound, rustling sound that is heard all over the lung field, that is vesicular. So remember, in terms of normal breath sounds, so B for the tracheal area, and then BV for the bronchi, and then V all throughout the lungs. So B, BV, and then V. So these are your normal breath sounds: bronchial, bronchovesicular, and vesicular. So if we have normal breath sounds, mute ko lang ha. So kindly mute your mic if you have excessive background noise. Okay. Sige. So going back, so if we have normal, we also have abnormal breath sounds. Okay, so abnormal breath sounds. What are these abnormal breath sounds? Okay, so with the abnormal breath sounds, we have the crackles, wheezing, rhonchi, friction rub, and stridor. So now, identify what is the description of the abnormal breath sound. So let's see if you can still remember your abnormal breath sounds. So ano ba yung common description yan? Let's begin with crackles. So when we see crackles, crackles is commonly described as musical, snoring, grating, or bubbling, or crowing sound. Very good, Arlene. So commonly crackles is termed as the bubbling, crackling, popping sound. Okay. What condition commonly will be expected to have crackles? Can you give me examples of condition wherein crackles could be expected or could be noted? So when do you actually expect crackles? Ano ba yung mga conditions that would manifest with crackles? Very good, pneumonia. So with pneumonia, there is increased secretions in the lungs, so there could be crackles. So increased secretions in the lungs. If there's congestion in the lungs, pulmonary edema, very good. Crackles will be noted. Okay, exactly. Anything else? Okay, so any condition wherein there's increased secretions in the lungs or congestion, like for example, fluid overload, right? So fluid volume overload, there could be pulmonary congestion. So there could be accumulation in the lungs as well. Okay, so COPD possible, okay, because there could be increased secretions in ARDS possible, okay, if there could be related to, especially if pneumonia is a common cause of ARDS, there could be crackles as well. Cystic fibrosis, okay, so possible there could be increased secretions in the lungs, so that is possible. Very good. So the crackling, popping, or bubbling sound, so those are expected to for crackles. So anyone with pulmonary congestion or fluid in the lungs or secretions in the lungs. So next, wheezing. How about wheezing? What is the description of wheezing? Musical, snoring, grating, or crowing sound? Musical, very good. So whistling, musical, or squeaking sound. Okay. When do we commonly expect wheezing? Kanino to commonly associated? What condition? Asthma, very good. Wheezing is a sign of what? Bronchoconstriction. So whenever you see wheezing, so that is bronchoconstriction. So that is why this is commonly associated in a client with asthma. Perfect. Okay, so wheezing, most common among asthma. So bronchoconstriction. And when do you usually expect to hear wheezing? When do you appreciate wheezing? During inhalation or exhalation? When do we more commonly hear wheezing? When we inhale or exhale? Very good. So exhalation. Okay, so parang whistling sound like in a client with asthma, right? So very good. And that is a sign of bronchoconstriction. Next, bronchi. How about bronchi? Snoring, grating, or crowing sound? Snoring sound, very good. So bronchi, snoring sound, that is usually heard with passage of air through an airway filled with mucus. So if there's too much mucus in an airway, so like for example in bronchitis, so common yan, bronchi. So there will be turbulent flow of air when the air passes through an airway filled with mucus. So that is bronchi. Next, friction rub. Friction rub is commonly described as grating or crowing? Grating sound. Very good. So friction, scratching, or grating sound. Okay, so commonly heard if there is scratching with what? The layer of the lungs, like especially in pleural condition, right? So with pleural condition, if for example there's inflammation of the pleura, so nagra-rub together yung internal and external pleura. So if it rub together, there will be friction rub. And lastly, wala na tayong choice. Okay, obviously, stridor is described as the crowing sound. So crowing sound. Ang stridor para din siyang wheezing. Okay? So this is related to what? Upper airway obstruction. Okay? So ang difference ng stridor with wheezing, stridor is related to upper airway obstruction, upper airway, versus wheezing. Wheezing is related to lower respiratory or lower tract obstruction. So like bronchoconstriction. So with stridor, para din siyang wheezing, so crowing sound, heard during inhalation or exhalation. Inhalation or exhalation? Kailan naman naririnig ang stridor? It is more commonly noted during inhalation. Very good. Okay? So para din siyang whistling sound or squeaking sound like wheezing. However, it is more heard during inhalation and it is related to upper airway obstruction like epiglottitis. Very good, Jo Marie. Epiglottitis, laryngotracheobronchitis. So there's obstruction in the upper airway. Very good. So yeah, and stridor, it is an emergency because that is a sign of upper airway obstruction. So those are the abnormal breath sounds. So very good. You are familiar with these abnormal breath sounds. So next, we will be discussing another hot topic, ABG, arterial blood gas interpretation. So are you very confident with interpretation of ABG? Kayang-kaya niyo ba ito? Siyempre, kayang-kaya nyo, di ba? Okay, so let's have a quick recap on how to easily identify ABG. So I'll be teaching you 3 easy steps. Kakayanin definitely, Eunice, na? Sige. So review natin yan para mas mapadali in your actual examination. So first step, check your pH. So with a pH, normal pH is 7.35 to 7.45. If pH is less than 7.35, it is low, we will consider problem as acidosis. If the pH is above 7.45, it is high, we'll consider this as alkalosis. So just by looking at the pH, that is our first step, alam na natin kung acidosis or alkalosis ang concern. So let's have an example. So for example, pH of 7.55, high, low, or normal. 7.55, it is higher than 7.45. Very good. So it is high. So if it is high, is it acidosis, alkalosis? What is the problem? So very good. In our example at the moment, it is an alkalosis. Okay, job well done. So ngayon, next step is to identify what's causing the alkalosis. Is it respiratory or is it metabolic? So how do we identify the cause? So by checking the CO2 in the bicarbonate. Always remember CO2 carbon dioxide, so CO2 partial pressure of CO2, normally it should be 35 to 45. And CO2 itself is a parameter of the lungs. So it signifies respiratory. So kanina, I have emphasized that the two buffer system, to maintain acid-base balance, we have the kidneys and we have the lungs. So CO2 represents the lungs. So meaning if there's problem with the CO2, it is a respiratory cause. On the other hand, we have the bicarbonate or the HCO3. Normal value is 22 to 26. Okay, so 22 to 26. And bicarbonate is a parameter that represents the kidneys. So if there's abnormality of the bicarbonate, it is a metabolic cause. Okay, and to be able to identify whether respiratory or metabolic, we will use the mnemonic ROME. So what does ROME means? Respiratory, opposite, metabolic, equal. Okay, so respiratory, opposite, metabolic, equal. So how do we use that? For it to be a respiratory cause, relationship of the respiratory parameter CO2 to pH should be opposite. Okay, so it should be opposite. So one is up, one is down. For it to be a metabolic cause, relationship of the metabolic parameter, which is bicarbonate, to pH should be equal or the same. So either both up or both down. Apply natin. So dun muna tayo sa CO2. CO2, 23, high, low, or normal? Is CO2 23, high, low, or normal? So normal CO2, 35 to 45. So this is low. And CO2, as mentioned, it is a respiratory parameter. For it to be a respiratory parameter, ano dapat relationship ng pH sa CO2? They should be opposite. Okay, so they should be opposite. Are they opposite? Yes or no? They are. Very good. So does that mean this is a respiratory cause? That confirms this is a respiratory cause? Yes, very good. So now we have identified that this is a respiratory alkalosis. Okay, so job well done. So respiratory alkalosis na tayo as of the moment. Most of the questions, these two steps will suffice. But sometimes we must be ready, right? So what if you are asked of the compensation? So we will study the third step, which is regarding compensation. Okay, pero pinaka-importanting step, yung one and number two. Okay. So additionally, if we want to know regarding compensation, so this is the third step. How do we know whether there is compensation or there's no compensation? So when we say, what do you mean by compensation? Ano bang pagkakaintindi nyo pag sinabing compensation? Okay, what do you mean by compensation? Dalawang buffer system yan, di ba? The lungs and the kidneys. Nag-a-adjust. Exactly, Angelica. Very good. Okay, pag may kulang ka sa something, you try to compensate or you try to adjust with a different thing, right? So, ganun yan yung ginagawa ng lungs and kidneys. See, or since there are the two system that promotes balance, if there is problem with the lungs, who will try to compensate? It would be the kidneys. So same goes, if there's problem with the kidneys, who will do the compensation? It's the lungs. So silang dalawa nagtutulungan. Okay? So if the lungs will be in trouble, the kidneys to the rescue. Okay? If the kidneys will be in trouble, and the lungs to the rescue to achieve balance. So that is compensation. So adjustment to achieve balance. Okay? So ngayon, how do we know whether there is compensation? Compensation, okay, you know there is compensation if both CO2 and bicarbonate are abnormal. So CO2 and bicarbonate, pareho silang abnormal. There is compensation. So meaning, may problema, for example, yung lungs, kapag nag-compensate yung kidneys, so there will be adjustment of value with the kidneys or the bicarbonate. So pareho silang abnormal. But if one between the two, okay, if one between the two is normal, okay, so that is uncompensated. Walang ginagawa yung isang system to help. So like for example, the CO2. CO2 is for the lungs, right? So the CO2 is in trouble. Okay, or the lungs will be in trouble, pero normal yung bicarbonate mo. So walang ginagawa yung kidneys to help or to adjust to achieve balance. Or, for example, ang may problema naman yung kidneys, HCO3 or bicarbonate is abnormal, pero normal ang CO2. So isa sa kanila ay normal. So walang ginagawa yung lungs to help. Okay? So that is uncompensated. So one between the two is normal, uncompensated. Both are abnormal, it is compensated. And if you have identified it is compensated, compensation can be partial or full. How do we look at that? By simply checking the pH. If pH remains abnormal, it's just a partial compensation. Versus if pH is normal, that is a full compensation. So going back to our example, may mga sagot na kayo. So now, problem here is respiratory. Lungs ang in trouble. So sino ang magko-compensate? Yung other system, the kidneys. So compensation will be reflected by the bicarbonate. If the value of bicarbonate is normal, walang ginagawa si kidneys to help or to compensate. Pag ang value ng bicarbonate is abnormal and same direction as the respiratory parameter, so that means there is compensation. So now, bicarbonate high, low, or normal? Normal, very good. So tumutulong ba yung kidneys para maka-achieve tayo ng balance? May ginagawa ba siya to achieve balance? Wala, normal lang siya, stay put lang siya, chill lang siya, no? Okay. So meaning, is this compensated or uncompensated? Uncompensated respiratory alkalosis. Awesome, very good. So that is our first example. Clear tayo sa mga steps and let's have more examples. Are we clear with the three steps? Yes, okay. Sige, let's try more examples para masanay kayo. Okay, so let's get the hang of it. So first example, okay, so practice, try to participate para natitingnan mo kung nakakasunod at nag-a-apply yung steps. So first pH of 7.51, high, low, or normal? Mataas. Okay, so 7.45, 7.35 to 45, mataas. If this is high, acidosis, alkalosis, acidosis, alkalosis, alkalosis. Very good. pH that is high, alka. pH that is low, acid. Okay, very good. Next step. Okay, so next step, identify what's the cause. So check natin yung CO2. CO2, pH CO2, high, low, or normal? 32. Normal is 35 to 45. It is low. Very good. So this is a respiratory parameter. For it to be respiratory, sabi natin following the mnemonic Rome, relationship of pH and CO2 should be opposite with each other. Are they opposite? Yes. So does that confirm this is a respiratory cause? So kung opposite yan, yes, posibleng respiratory cause. So good job. You have identified this is respiratory alkalosis. So next, last step, compensation. So kung lungs ang may problema, kidneys ang magko-compensate. Value of bicarbonate, very good, normal naman. So tumutulong ba yung kidney para mag-compensate? Nag-adjust ba siya para mag-compensate? Wala. Very good. So meaning compensated, uncompensated. Uncompensated respiratory alkalosis. Great job. Next example, pH of 7.28, high, low, or normal? 7.28, mababa. Okay. If pH is low, acidosis, alkalosis, acidosis. Okay, great job. CO2, 54, high, low, or normal? It is high. 35 to 45 ang normal, mataas. CO2, CO2 is the parameter for the lungs or for the kidneys? For the lungs. So for the lungs, respiratory. For it to be a respiratory cause, opposite dapat sila. Are they opposite? Yes, so that confirms this is a respiratory cause pa rin kasi opposite ng pH and CO2. So ganun pa rin, compensation will be done by the remaining parameter, by the kidneys. Pag ang value ng kidneys ng CO2 is normal, no compensation. But if it's also abnormal, there is compensation. Bicarbonate, 30, high, low, or normal? Mataas, okay, 22 to 26, so this is high. So are your kidneys trying to compensate? Are your kidneys trying to adjust to achieve balance? Yes, very good. So compensated, uncompensated? Compensated. Very good. So sure ka na may compensation. Sabi natin kanina, pag compensation, merong partial, merong full. It is considered partial if pH is abnormal. It is considered full if pH is normal. pH is abnormal. So partial lang. Very good. This is a partially compensated respiratory acidosis. Okay, very good. So partially compensated respiratory acidosis. Tatandaan nyo rin na ang CO2, CO2 in nature, acid ang CO2. That's why the more CO2 you have, so the more acid also you have. Okay? So kagaya nito, pag mataas ang CO2 sa katawan mo, so that causes acidosis. And bicarbonate is alkaline naman in nature. So opposite sila. So bicarbonate is alkaline in nature. Kaya mapapansin nyo with compensation, since marami kang acid, anong gagawin ng katawan para ma-achieve yung balance? So papataasin din ng katawan yung alkaline mo, yung basic, para ma-achieve mo yung balance. Diba? If you have too much acid, so the body will try to increase the alkaline to achieve the balance. Okay? So that is for the second example. Following tayo. Clear tayo so far? Nakakasunod? Sige. Okay. Third example. Third example. pH of 7.54, high, low, or normal? High. Okay. Since mataas to, acidosis, alkalosis. Very good. So definitely, this is alkalosis. Okay, so next, CO2 60, high, low, or normal? Mataas din. For this to be a respiratory cause, they should be opposite. pH and CO2, are they opposite? It's not. So can this be a respiratory cause? Hindi, no? Okay, so punta tayo dun sa next. Bicarbonate 32, high, low, or normal? Mataas. For it to be a metabolic cause, your bicarbonate and pH should be equal. So same direction, both up or both down. Since both are up, they're equal. So respiratory, metabolic. Awesome. So this is a metabolic cause. Very good. Since this is a metabolic cause, compensation will be done by your lungs. If abnormal ang value ng lungs, so that is compensated. If normal siya, uncompensated. Abnormal din siya, same direction. Okay? So compensated, uncompensated. Compensated. Partial or full, pH is abnormal. Partially compensated, metabolic alkalosis. Awesome. Okay, so good job with our third example. Okay, so last example. pH of 7.37, high, low, or normal? Normal. Okay, so normal siya at the moment. How about the CO2, high, low, or normal? So CO2 is mababa, 35 to 45. So that is low. How about bicarbonate, high, low, or normal? Mababa din. Okay. pH is normal at the moment, pero abnormal yung CO2 and bicarbonate. So, hindi pa rin to normal ABG. So, there's an imbalance pa rin. So, how do we identify the problem if pH is normal but CO2 and bicarbonate are abnormal? Balik tayo sa pH. So, with the pH, to be able to identify whether acidosis or alkalosis, so identify saan ba siya closer. If it's closer the lower limit, we'll consider this as low or acidosis. If it's closer to the upper limit, which is 7.45, we'll consider this as high or alkalosis. So saan ba siya mas malapit? Sa lower or sa upper limit? Sa lower limit. Very good. So mas malapit sa 7.35. So we'll consider this as low, which is acidosis, alkalosis. Acidosis. Very good. Okay? So meaning acidosis ang concern natin. So ganun ulit, go back to the step. So if this is low, CO2 is also low. Are they opposite? It's not. So it cannot be a respiratory cause. So let's check the pH versus the bicarbonate. pH and the bicarbonate should be equal for it to be metabolic. Are they equal? Low and low? Yes. So respiratory metabolic cause. Definitely metabolic. Very good. Compensated, uncompensated. Both are abnormal. Parehong abnormal. So surely compensated. Partial or full. Balik sa pH. Yung pH mo normal. So very good. This is an example of a fully compensated metabolic acidosis. So pag yung pH normal na-achieve yung balance, no? So full compensation. Okay, very good. So those are examples for ABG interpretation. Are we clear? Kayang-kaya? Yes. Very good, everyone. Doing great. Okay, so keep up the good work. Now, another common question in the examination, you might be asked of what conditions can be associated with the different acid-base imbalances. Diba? And this could be helpful for us as well kapag binanggit yung mga condition na to, may clue ka na agad what to expect na acid-base imbalance sa kanila. Para pag binigyan ka, you receive a client with COPD. So which of the following ABG value do you expect to find? So nakita mo pa lang yung COPD, alam mo na agad kung anong acid-base imbalance ang i-expect mo sa kanya. Okay, so without even checking the values yet, you know what to identify. So let's identify what are conditions or scenarios that will be associated to either respiratory acidosis or alkalosis. Hypoventilation. Will that lead to acidosis, alkalosis? Hypoventilation. Acid, very good. Okay? So pag sinabi nating respiratory acidosis, common scenario dyan is mataas ang CO2. Okay? So mataas ang CO2 because CO2, so respiratory parameter is CO2 and CO2 itself is acid. With hypoventilation, when you are hypoventilating, so there's increased retention of CO2, right? How about if you're anxious? Acidosis, alkalosis? Very good. Okay. Bakit nagkakaroon ng alkalosis kapag anxiety when you are anxious? Because part of anxiety is you will be what? Ano bang common symptom if you are anxious? So when you are anxious, you could be hyperventilating as well. In case RR, very good. So now we know exactly hyperventilation, the opposite of hypoventilation, leads to alkalosis as well. Because with increased respiratory rate or hyperventilation, you are blowing off CO2 too much. So nailalabas mo excessively si CO2. Very good. COPD, acidosis alka. Acid din. Kasi later on, we will be discussing in COPD, there's trapping of the CO2. So due to bronchoconstriction, there's trapping of the CO2. There's CO2 retention as well. Asthma. So dito with asthma, meron tayong early versus late. Early stage of asthma, acid alka. Alka. Because with early attack of asthma, acute attack of asthma, hyperventilating pa yung client mo in case RR pa. Okay, so due to dyspnea, very good. But with late stage of asthma, what do we expect now? Just like in COPD, there's bronchoconstriction already. So there will be trapping of CO2 na. Kaya very important in your examination, be mindful of keywords like early, late. Okay, kasi the acid-base imbalance would vary as well. Job well done. Fear, hysteria. Alka din, no? So pareho with anxiety, fear, hysteria, all related to hyperventilation. So anything related to hyperventilation. So you're losing or blowing off CO2. Increased intracranial pressure, increased ICP. Acid, oo. Bakit nagka-risk for acidosis kapag increased ICP? Why acidosis, respiratory acidosis is possible for increased ICP. Bradypnea, very good. Exactly, Angelica. No? So there could be retention of CO2 as well due to bradypnea, decreased RR, okay, hypoventilation. Excessive mechanical ventilation, acidosis, alkalosis. So parang hyperventilation din yan, no? So too much ventilation from the mech vent for respiratory alkalosis. Okay, very good. So that's why usually, kapag naka-mechanical ventilator yung patient natin, tapos, di ba, nag-ABG check din from time to time ang doctor. And then, so yung pulmo doctor natin, nag-check ng ABG, so nanonotice na yung pulmo doctor, nagre-respiratory alka yung patient natin, so posibleng bababaan na, no? So start to wean off the patient from ventilator, bababaan na yung setting ng mech vent. Okay, because the patient might be receiving too much ventilation already, especially with improved own respiratory effort. Very good. So that is respiratory acidosis versus respiratory alkalosis. Are we clear with this one? Clear tayo so far ha? So ngayon, paano naman kapag metabolic? Okay, so for metabolic, identify whether acidosis or alkalosis pa rin. DKA, diabetic ketoacidosis. So that leads to metabolic acidosis. Very good from the name itself. So there's increased ketone that causes the acidosis, right? Very good. Ano yung common respiration noted in a client with DKA? What is the common symptom in terms of respiration? Kussmaul's breathing, very good. So Kussmaul's breathing, that is a compensatory mechanism in a client with DKA, no? Okay, to blow off the excess acid. Okay, very good. So DKA, Kussmaul's breathing. So you know exactly po nagka-Kussmaul's breathing na yung client mo na diabetic, so that could be a sign of diabetic ketoacidosis, so related to metabolic acidosis as well. Severe vomiting. Alkalosis, very good. Because with alkalosis, with severe vomiting rather, you are losing gastric acid. So you're losing gastric acid and then leads to alkalosis, right? Very good. GI suction and drainage. Ganun din. Yes, kasi with GI suction and drainage, ganun din, you are losing gastric acid din. Okay, so you're losing gastric acid din. Okay, very good. How about for diarrhea? Acidosis naman, very good. So with severe diarrhea, you are losing intestinal content naman. Intestinal content is alkaline. So you are losing alkaline. Kaya that leads to acidosis. Versus gastric loss, so that leads to alkalosis kasi gastric, so secretions natin acidic. Okay, so you're losing gastric acid. Job well done. Excessive sodium bicarbonate. Alkalosis, exactly, because bicarbonate itself is alkaline. So if you have too much alkaline, so definitely alkalosis. Very good. Kaya yung may metabolic alkalosis, binibigyan ng sodium bicarbonate. Okay, job well done. Renal failure. Perfect. So with renal failure related to acidosis, there's retention of renal acids. Okay, so inability of the kidneys to excrete the renal acids. How about hyperkalemia? Hyperkalemia, very good. Okay, with metabolic acidosis, potassium leaks out of the cell. So opposite of that, hypokalemia related to alkalosis naman. No? So with metabolic alkalosis, the potassium moves inside the cell. So leading to lesser potassium outside the cell. So hypokalemia, job well done. Use of loop diuretics. Loop diuretics. Oh, okay. So with loop diuretics, so you are losing your renal acids, diba? Increased excretion of renal acids. So definitely that could lead to metabolic alkalosis. Lastly, aspirin toxicity. Acidosis, very good. With aspirin toxicity, that increases lactic acid release. So acid. So that's why it leads to metabolic acidosis. So kaya kapag may lactic acidosis, so anything related to lactic acidosis, MI, burns, diba? There's increased release of lactic acid. So that can lead to metabolic acidosis as well. Okay. So these are the possible conditions that could be related to metabolic acidosis versus metabolic alkalosis. So be familiar with these conditions para may clue ka na agad in the examination. Sa question pa lang, nakita mo, your patient is diagnosed with DKA, your patient is diagnosed with diabetes mellitus, that complicated to diabetic ketoacidosis. So which of the following acid-base imbalance would you likely expect? So may idea ka na agad what to look for. Okay? So those are the possible causes. Are we clear with this one? Yes. Okay, sige. So, aside from that, what are the common respiratory treatment na binibigay natin for patients with different respiratory conditions? So, first, common that we give, oxygen. Oxygen is an inflammable substance, but it can support combustion. So, meaning by itself, it would not cause fire. However, if it's combined with other agents of combustion, pwedeng magkaroon ng sunog. So, that's why very important na teaching, if your patient is on oxygen therapy, no smoking. Diba? So no smoking sign is placed. So si patient di pwede mag-smoke, definitely, even the visitors or anyone near an oxygen therapy. So no smoking. Also remove woolen blankets and friction toys because friction can support combustion. So that should be avoided as well. So to prevent fire. And with giving oxygen, hindi tayo pwedeng basta-basta magbigay ng oxygen because oxygen is a dependent nursing intervention. So when we say dependent, it requires doctor's order for us to be able to give oxygen, diba? So hindi tayo pwede basta magbigay ng oxygen kay patient. So this requires doctor's order. And very important if your client is on oxygen therapy, so make sure patient is hooked to humidifier as well because humidifier, one common side effect of oxygen therapy, especially high level of oxygen, this could cause dryness of mucosa. Humidifier would prevent the dryness of mucosa. So expect pag naka O2, may humidifier, okay, to prevent the dryness of mucosa. So to promote comfort din ng client natin. So just a nice to know information, what are common examples ng mga O2 devices that we use? So we have the nasal cannula, simple face mask, ito yung pinaka-common na nakikita natin. No? So initially, kung low lang, oxygen ang kailangan, nasal cannula, nasal prongs, sa ilong lang. So the good advantage of this one, the patient can easily eat, drink, talk, even with oxygen therapy kasi nasa ilong lang. As compared to the simple face mask, this covers the entire nose in the mouth. Okay? So kaya usually kung kakain si patient, tinatanggal pa yung face mask. So pwedeng i-hook mo muna sa nasal cannula while the patient is eating. and then just put back the simple face mask when the patient is done. So ito yung pinaka-common. Then cannula and also the simple face mask. Pabalik sa last slide, no problem. This one. So always remember with oxygen, we can only give oxygen as ordered. Okay, so as per order. So it is a dependent nursing intervention. This one, Refi, ito ba? Okay na tayo. Sige. Okay, so as mentioned, we have nasal cannula, simple face mask. Okay, no need to actually memorize. So nice to know information lang. Yung FiO2 liters per minute, di naman siya tinatanong usually na kung ilang liters per minute lang, no? Okay. Kahit 2 liters per minute, usually during emergency, Mia. So for example, during emergency, the safest we can give is yung lowest nga. So 1 to 2 liters per minute. So maximum 2 liters. But beyond that, we cannot give. Okay, that requires doctor's order. So during emergency, the one that we can give without doctor's order up to 2 liters per minute, that's the safest. But beyond that, hindi pwede. Okay, so that requires doctor's order, especially high level of oxygen to prevent oxygen toxicity as well. So that is the nasal cannula, simple face mask, the most common. And also, we have the partial rebreather versus non-rebreather. Nakakita na kayo nito? Ano bang difference nila? So you will notice pareho silang may reservoir bag. With partial rebreather mask, so let's differentiate. So from the name itself, partial rebreather, you rebreathe what you previously exhaled. Okay? So with partial rebreather mask, the bag contains high level of oxygen. So when the patient inhales, nai-inhale ni patient yung high level ng oxygen. And then when the patient exhales, part of what the patient exhales goes back into the bag. So part ng na-exhale niya, napupunta ulit doon sa reservoir bag. Kaya pag mag-inhale ulit si patient, so the patient is able to rebreathe part of what he or she exhaled. Kaya tinawag na partial rebreather mask. So yung valve dito, two-way. May papunta kay patient, may pabalik sa bag. Okay, so that's why you are able to rebreathe what you exhaled. Okay, so you are able to rebreathe partially what you exhaled. Okay. This is advantageous especially for patients who are hyperventilating. Kasi with hyperventilating, sabi natin kanina, the problem or the concern, you are losing too much CO2, right? So you are losing too much CO2. So to prevent you from losing too much CO2 that could lead to alkalosis, so kaya management natin kay respiratory alkalosis, so partial rebreather mask. Okay? So that you will be able to rebreathe part of what you exhale. Ano yung common na ginagamit natin pag hindi yan available? So for example, us being resourceful nurses, nakakita ka nag-hyperventilate sa supermarket. Anong binigay mo sa kanya? Very good, the brown bag method or the brown bag technique, no? So binigyan mo siya ng brown bag. Well, how do you teach the client to use that? Nagkakita mo may nag-hyperventilate sa supermarket. So binigyan mo siya ng brown bag, you instruct your client, inhale muna siya sa environment. So outside the bag. And then, exhale inside the bag. Okay, pagka-exhale niya inside the bag, mag-inhale naman siya ulit next from the inside the bag. Para the patient is able to rebreathe what he or she exhaled. Diba? So, rebreather, para siyang rebreather. So, you are rebreathing part of what you exhaled to prevent excessive loss of CO2. So, yun yung partial rebreather. Okay? So, in comparison to non-rebreather, from the name itself, non-rebreather, you do not rebreathe what you exhaled. Okay? You do not rebreathe what you exhaled. So, yung reservoir bag dito will just contain high level of oxygen. So, when you inhale, you are inhaling high level of oxygen. So, going into your patient. When you exhale, yung in-exhale mo, hindi babalik sa bag. It goes out into an exhalation port going into the environment. So, palabas. Hindi bumabalik sa bag. So, yung valve dito, one way lang. Papunta lang kay patient. Hindi pabalik ng bag. So, that's why you do not rebreathe what you exhale. Okay, so nai-inhale mo lang, high level of oxygen. That's why this is commonly used while awaiting for intubation. So severely dyspneic na yung client mo, bumabagsak na yung O2 sat, and you're just preparing yourself for intubation. Client's respiratory status is deteriorating. So while waiting, pwedeng naka non-rebreather mask si patient so that the patient is receiving high level of oxygen. Okay, so that is partial rebreather versus non-rebreather. Clear tayo dito? Yes? Okay, sige. So moving forward, severe cases of respiratory condition, it would require mechanical ventilation use, right? And for you to be able to, for you to be hooked to a mechanical ventilator, so we have to have an airway. That is through your ET tube or the tracheostomy tube. Okay, so kapag required ka ng IMEC vent, kailangan natin ng endotracheal tube. So with the endotracheal tube, so from the name itself, endotracheal, a tube that is inserted from the mouth down the trachea. So ET tube. So with this one, so this is commonly used for short term lang. So max, ideally, so the ideal is 2 weeks. Okay, so ideally, 2 weeks use. Why do we limit the use of ET tube to 2 weeks? Bakit hindi pwedeng isang taon ka naka-ET tube? What is the purpose of limiting it for short-term use? Very good. To prevent ventilator-associated pneumonia. Okay, to prevent infection. The longer you are on ET tube, this is an artificial airway, so the higher the risk of pneumonia. Very good. Okay, so to prevent that, so usually short-term lang ginagamit to. If, for example, more than 2 weeks na, pero hindi ka pa rin ma-wean off from mechanical ventilator, kailangan mo pa rin ng tulong ng MECVEN. And para lesser yung risk for ventilator-associated pneumonia, you could be shifted into a tracheostomy tube. Okay, so that we will be discussing in a while. So more short-term as compared to tracheostomy. So mapapansin nyo, meron inflated cough dito. So that inflated cough will be monitored every shift. So every 8 hours. Should not exceed more than 20 millimeter mercury. So there's proper pressure. Every shift, chine-check yung pressure niyan kung proper para ma-prevent yung complication. At the same time, ma-prevent din yung na ma-remove because that serves as an anchor as well. Very important for a newly inserted endotracheal tube, priority is to check proper placement. Okay, so priority is to check for proper placement. So what are ways to check for proper placement? X-ray. Because with X-ray, doctors are able to visualize where is the tip of the tube. Kung talagang na-insert ng tama. Diba? So check for bilateral chest expansion. So dapat kapag after a newly inserted ET tube, sabay na nag-inflate, deflate both left and right side of the chest. Okay? Para alam mo na equally ventilated yung lungs. So same goes when you auscultate for breath sound, you should appreciate breath sounds equally on both left and right lungs as well. And of course, we auscultate over the stomach. Anong kinalaman ng pag-auscultate sa stomach? Respiratory system to. Bakit sa stomach tayo nag-auscultate? Any idea? Why do we auscultate in the stomach as well as part of checking for proper placement of ET tube? Very good, Marjorie. That is correct, Angelica. So as mentioned a while ago, the pharynx the pharynx, both passageway of food and air. Parehong connected, yung pharynx connected pareho sa GI and respiratory tract. So pag in-insert yung ET tube, there could be a risk that it was not inserted down into the respiratory tract, but into the GI tract. Very good. So napunta sa esophagus. Okay, so anong ma-ventilate? Yung stomach mo. 'Di ba? So pag ang napansin mo ang nag-e-expand ay ang stomach, so abdominal intubation 'yon, no? So that is incorrect intubation. So that's why you have to assess as well. Okay, very good. So that is the essence why we auscultate over the stomach. Okay, so to check for incorrect insertion, incorrect site. Among these method, which will be the best to check? Which would be the best? X-ray, definitely. Very good. So among these method mentioned, X-ray ang pinaka the best. Okay, very good. Kasi with X-ray, the doctors clearly visualizes nasaan yung tip of the tube. Okay, great job. So as mentioned, for example, more than 2 weeks na, pero hirap pa rin si doctor tanggalin si client from the MECVEN. And then, the patient would be a candidate for creation of tracheostomy. So, ililipat yung kanyang artificial airway through a tracheostomy. So, ito surgical approach siya. So, with the tracheostomy, so that will be inserted directly into the trachea. Okay, so this can be something temporary kung our airway lang yung purpose niya, but for other patients, so this could be something permanent as well. Okay, so this could be used more longer term as compared to your ET tube. Okay, kaya sabi natin kanina, kapag more than 2 weeks ka na naka-ET tube tapos kailangan mo pa rin ng mech vent, so you could be shifted to tracheostomy. So very important, tracheostomy care. Of course, if you have a tracheostomy, every shift yan ginagawa. So to make sure na hindi din mababarahan yung ating tracheostomy tube because that will serve as your airway already of the patient. So kapag naka-tracheostomy ang patient, there's change of airway already. The patient, yung in and out, diba sabi ko kanina, in a normal person, we breathe into the nose, we exhale through the mouth. In a client with tracheostomy, yung entry and exit of air through the stoma already, through the tracheostomy, through the opening in the trachea. So there's change of airway. So tracheostomy care every shift is very important as well. Ambu bag, obturator, spare tracheostomy tube of the same size should be at bedside all the time so that in case magkaroon ng dislodgement of the tracheostomy tube, so we have something that we can use as well. Okay, so generally speaking, if your client has these artificial airways, the ET and tracheostomy tube, very important, you have to position patients semi to high Fowlers. So as much as possible, hindi pwedeng naka-flat on bed yan all the time. So dapat laging naka-elevate yung head of bed, at least semi-Fowler's position. For what purpose? Bakit kapag may ET, pag may tracheostomy, dapat naka-semi to high Fowlers? Why that position would be best for someone with ET and tracheostomy? To prevent what? To prevent, okay, so to promote lung expansion, pwede naman. Okay, but more importantly, to prevent what? Aspiration. Okay, very good. So more importantly, to prevent aspiration. So that's why kapag naka-ET, naka-tracheostomy, so dapat naka-elevate yung head of bed, at least semi-Fowlers man lang. Okay, so ambo bag or the resuscitation bag should always be at bedside. Because in case magkaroon ng respiratory distress yung client mo, magkaroon ng problema sa mech vent, so you will manually ventilate your client through the ambo bag or the manual resuscitation bag. And whenever you access these tubes, the ET tube and tracheostomy, sterile technique. Okay, so sterile technique should be maintained. So whenever you, for example, magsasuction ka sa ET tube, magsasuction ka sa tracheostomy, sterile technique. Okay, so very important yan. So sterile technique. And whenever we suction as well, we hyperoxygenate client both before and after suctioning. So to prevent excessive loss of O2. Kasi kapag nagsasuction ka, so there could be loss of oxygen as well, right? So make sure to hyperoxygenate first before, and then pag natapos mag-suction, hyperoxygenate again your client after. So those are important measures in a client on ET and tracheostomy. And as mentioned, if your client is placed with ET and tracheostomy, so this will serve as the artificial airway so that your client can be hooked into a mechanical ventilator. So yun yung next topic na i-discuss natin, the mech vent. Okay, so before the mechanical ventilator, we have another O2 device, so another non-invasive ventilation device, which we call CPAP or the BiPAP. So with the CPAP, continuous positive airway pressure, BiPAP, bi-level positive airway pressure. Ano bang binibigay ng CPAP at BiPAP? This gives pressurized air, positive airway pressure. So pressurized air yung nare-receive ng patient natin. So ito hindi kailangan ng ET tube and tracheostomy. So ito external lang, kay non-invasive. So pwede siyang orofacial mask. Okay, so orofacial mask or nasal mask. So sa nose lang. Pero pinaka-common yung both covering the nose and the mouth. So orofacial mask. Okay, so this can be indicated for patients with COPD, for asthma, but most commonly for client with sleep apnea, obstructive sleep apnea. So later on, i-discuss natin si sleep apnea, hot topic yan sa examination. Okay, so madalas na prescribed with CPAP, especially with home use, those are with patients with obstructive sleep apnea. So portable device lang yan, maliit lang siya, that could be at bedside table to give client pressurized air. Okay, so pressurized air. Since patient is receiving pressurized air, common side effect as well is dryness of mucosa. Humidifier is beneficial kapag naka-CPAP or BiPAP. Hot topic in the examination. Natanong yan recently in the examination. So yung mga current passers natin, mga recent passers natin for the month. So natanong sa kanila kapag naka-CPAP, naka-BiPAP, so importante na may humidifier to prevent dryness of mucosa. Okay, so that is the CPAP or BiPAP. Pinagkaiba ni CPAP and BiPAP, continuous positive airway pressure, yung pressure na na-receive ni patient during inhalation and exhalation, isa lang. Isa lang yung setting. So same pressure for inhalation and exhalation, continuous. But with BiPAP, from the name itself, bi-level, so yung sineset ni doctor na pressure during inhalation versus exhalation, pwedeng magkaiba depending on the need of the client. Okay, kaya tinawag siyang bi-level. So kung kailangan magkaiba yung pressure during inhalation and exhalation, so yun, BiPAP usually. Okay, so with CPAP, one level lang. So isa lang yung pressure. Alin po yung mas effective? So it depends on the need of your client. Oh, so depende yung kasi pareho naman siyang pressurized air yung ma-receive ng client, but depending on the need of yung client. Kung continuous pressure lang naman yung kailangan natin, like for example, kailangan lang ni client na, like for example, a client with sleep apnea. So gusto lang natin ng continuous pressure para to prevent the blockage of the airway kasi ang problem with sleep apnea, nagkakaroon ng um, obstructed airway, diba, whenever they sleep. So to keep the airway open, so kailangan lang may continuous pressurized air. So pwedeng CPAP, diba? So dependent just on the need of the client. So kung kailangan na magkaiba, so that's the time na with bi-level or the BiPAP can be used. Naka-hook din po, naka-hook din sa O2 yung BiPAP. So usually with ito more of pressure. So not rate of oxygen ang ina-adjust sa kanya. It's more of pressurized air. Oo, wala siyang O2. So pressurized air. Kaya kapag for example, in CPAP as mentioned a while ago and BiPAP, hindi pag for example, si patient mo may like in COPD or in asthma nahihirapan silang huminga, kung i-adjust yung setting niyan, it's the pressure that will be adjusted, not a rate of oxygen. So wala siyang oxygen. Okay, so hindi siya O2 device kagaya ng mga nabanggit natin na kanina na nasal cannula. Oo. Okay. So yan. Pressurized air siya. So kaya ang purpose niya is giving positive airway pressure. Pressurized air only. So not oxygen. So wala ding ina-adjust na O2 level dyan. Pressure lang. Okay? So yan. Next, we have, so sabi natin kanina, yung naka-ET tube tsaka naka-tracheostomy, sila yung kinakabit sa mech vent. Diba? So for us to be able to use a mech vent, dapat meron tayong artificial airway, which is the ET tube or the tracheostomy. There are different settings of the mechanical ventilator. We have the CMV, AC, SIMV. Okay, so let's differentiate the settings. Pag sinabi nating CMV, controlled mechanical ventilation. Okay, controlled mechanical ventilation, full support nakukuha mo from the mech vent. So these are commonly indicated for patients na are unable to initiate. So for clients who cannot initiate their own respiratory effort. Apneic patient. Okay, so apneic patient. So meaning, yung full na paghinga mo, di ba pag sinabi nating apnea, absence of breathing. Okay, so yung full na ventilation is the mechanical ventilator alone. So fully dependent on the mech vent. So that is controlled. That's why from the name itself, controlled, full control from the mech vent. So for patients who are apneic. Okay. Commonly used, we have the AC. With AC mode, this can be used for patients na may own respiratory effort. However, it's not enough to fully support yung breathing nila. So, may respiratory, hindi sila apneic. So, meron naman silang own respiratory effort pero kapos. Kailangan ng tulong. So, anong setting ang isa-start natin? AC. So, with AC mode, from the name itself, assist control. So, another term is continuous mandatory ventilation. The help that the ventilator gives would be continuous. So it provides fixed volume and fixed rate. So for example, sinet ni doctor sa McVent is a volume of 750. So 750 ml tidal volume and then 20 breaths per minute rate. So yun yung sinet ng doctor sa McVent. regardless whether you are breathing on your own or not, the mech vent will continuously give 750 ml at 20 breaths per minute. Continuous yun. Regardless whether you are breathing on your own or not. So whether you are initiating your own breath or not, fixed, continuous yung ibibigay ng mech vent. Okay? So wala siyang pakialam dun sa own respiratory effort mo. Basta ibibigay niya kung ano yung nakaset. Malinaw tayo doon? So with controlled, wala kang own breathing. Si McVent lang ang full in charge sa'yo. With AC, you have your own breathing however you needed support. Pero yung support na binibigay with AC, continuous. Full, kung ano yung nakaset, continuous niyang ibibigay whether you initiate your own breath or not. Are we clear with AC? Malinaw tayo? Nakuha? Yes, okay. Compare natin with SIMV. With SIMV naman, synchronized, intermittent. So kanina continuous, ito intermittent. So SIMV, synchronized, intermittent. So nakasynchronize siya sa own respiratory effort mo. Okay? So ito ginagamit kapag nag improve na yung breathing mo. So like for example, you started AC mode, and then, nag-improve na yung own respiratory effort mo. So, medyo mas kinakaya mo na minsan. Okay? So, pwedeng babaan na ni doctor. So, for example, nag-ABG si doctor, nagre-respiratory alkalosis ka na. So, meaning, nag-improve na yung own respiratory effort mo. So, babawasan ni doctor yung setting. So, pwedeng, for example, i-wean off ka, bababaan to SIMV. So, with SIMV, you have your own, this allows you to have your own respiratory effort. So, allows you to breathe spontaneously. So meaning, kanina, humihinga ka naman on your own. Pero kasi madalas kapos eh. Kaya fix pa yung binibigay ng McVen. So wala siyang pakialam on your own breath. Pero with SIMV, synchronize siya with your own breath. So pag na-sense ng McVent na kaya mo naman, nare-reach mo yung target. Okay, nare-reach mo yung target na volume and target rate, hahayaan ka lang niya to breathe spontaneously on your own. Pag na-detect ng McVent, ay kapos yung hininga mo, tulong tayo. So saan siya? Saka siya magte-take over. Kaya siya intermittent. Okay? Unlike dito, you are breathing spontaneously. However, walang pakialam yung McVent sa own spontaneous breath mo. Continuous yung ibibigay niya na ventilation. With SIMV, kapag na-sense na yung own respiratory effort mo is enough, it would let you do so. But kapag na-sense niya na kapos, that's the time it would give an intermittent help or ventilation. So pag kinakapos ka, pag kinukulang ka. So kaya usually si SIMV would be a lower setting from AC kapag mag-i-improve na yung sarili mong respiratory effort. Clear tayo with AC to SIMV? So dito continuous yung binibigay ng VEC-vent regardless whether you're breathing on your own or not. With SIMV, so intermittent lang, pag kailangan lang. Okay, pag kinakapos ka. Kaya usually pababa ng pababa yan. So from AC and then SIMV. So from SIMV, medyo nag-improve ka pa lalo. So bababaan to CPAP. Okay, so eventually, like for example, ma-extubate ka na, and then hook ka na lang to face mask, and then nasal cannula, and then eventually, kung kakayanin mo na mag-room air. So that's the goal. Weaning off from the ventilator the soonest possible. Okay? Kasi the longer time you are on mechanical ventilator, the higher that chances as well that you will get infection, yung tinatawag nating ventilator-associated pneumonia. So hanggang i-improve yung breathing, yung own respiratory effort mo, so bababaan ng bababaan yung setting. Okay? So what are factors that could affect or could prolong the time that you will be weaned off from the mechanical ventilator? Ano mga pwedeng factors na maka-prolong na ma-wean off ka from the ventilator? Can you give me an example? Ano mga yung mga pwedeng maka-prolong ng pagme-mech-vent mo? So usually, those that will have a harder time to be weaned off the ventilator kapag smokers. So mga smoker patient, usually mas mahirap i-wean off from the mechanical ventilator. So of course, so since they are smoking, diba, yung respiratory function nila would be much lesser as compared to non-smokers. What else? Elderly. Elderly clients, mas mahirap usually i-wean off from mechanical ventilator. Especially, of course, in terms of age, diba? So that could be a factor. And also, if the cause why you are on mechanical ventilator is a respiratory condition, so you have a respiratory condition, so that could be a factor to have a prolonged use of mechanical ventilator as well. So it is harder to wean off a client who is a smoker, elderly, and with a current respiratory condition, from harder to wean off from mechanical ventilator. Kapag smoker, may respiratory condition, and elderly. Okay, so those are the common factors. Hot topic in the examination, if a client is on mechanical ventilator, what are the alarms that can be noted sa McVent, di ba? So meron tayong high pressure versus low pressure alarm. So now identify to me whether the scenarios will lead to high pressure versus low pressure alarm. Identify natin. Okay? Sige. So para may picture kayo, para maka-identify natin, pag sinabi nating high pressure alarm, mataas ang pressure within the mechanical ventilator system. Generally ba, ano yung nagkukos ng high pressure within the mechanical ventilator system? Kapag may bara, okay, there's obstruction. Anything related to obstruction in the flow of air from the mech vent, mag-high pressure alarm yan. Versus with low pressure alarm, kailan naman naglo-low pressure alarm? Pag mababa yung pressure within the mech vent system, meaning nagli-leak out yung air from the mech vent. So, tingnan natin what are factors associated to such. Wheezing, bronchospasm, high or low pressure alarm. Very good. So, wheezing, sign of airway obstruction. Obstruction, high pressure. Very good. In case airway secretions, secretions can cause obstruction then sa flow ng air, di ba? So, that is high pressure. Very good. Anything related to obstruction. Patient stops spontaneous breathing, naga-apnea episode yung client mo. Apnea. So kung apneic, mababa yung pressure, no? Very good. Low pressure. Endotracheal tube is displaced. Pag sinabi nating displaced, the tube is still in but not in proper position. So in pa yung tube, hindi pa natanggal, pero not proper position. So kung not proper position, pwedeng mababarahan, no? Kasi hindi tama yung pagka-insert. So that would be, kung may bara, high pressure yon. Okay? Versus kapag natanggal na yung tube totally, nagli-leak out na yung air. So then magiging low. So pag displaced pa lang, high. Pero pag natanggal na yung entire ET tube, that's the time it becomes low pressure alarm. Okay? Patient fights the ventilator. Nagkakaroon ng mismatch of the breathing of your patient versus the ventilation given by the ventilator. Very good. Naglalaban. So, high pressure yon, di ba? Okay, very good. So, ganun din kapag anxious yung client mo, agitated yung client mo, habang naka-mech-vent, especially for first time na na-mech-vent, tapos awake yung client, no? So, pwedeng hindi nagsasabay yung own respiratory effort mo versus with the mech-vent. Nilalabanan, exactly, di ba? Common yun, lalo na kapag, for example, bigla silang na-awaken. Bigla silang na-awaken, tapos nagulat na lang sila na naka-ET tube sila, tapos first time pa nila. Oh, exactly. Yung nightmare natin, no? So, yun yung nightmare natin na kapag pasok mo ng tube, nasa sahig na pala yung ET tube mo, no? Kasi una nilang instinct, tanggalin, di ba? Kasi it feels like a threat to them. Okay? So, that causes high pressure alarm. Okay? Disconnection. Disconnected. So, disconnected, magli-leak out, low pressure yon. Kinks in the tubing. Pag may kinks in the tubing, so kink will cause obstruction as well, high pressure pa rin. Obstruction in general, nabanggit na natin, high pressure. Leak in the ventilator tubing. So, disconnection, leak. Nagli-leak sa tubing, maglo-low pressure alarm yan. Very good. Nagli-leak out. Oh, ito na, natanggal ang greatest nightmare natin, no? So, uuwi kang nag-IR, nag-self-extubate na yung patient mo, natanggal na pala yung ET tube, no? Naririnig mo, ba't mo nag-a-alarm yung mech vent ko? Tapos nakita mo, nasa sahig na palang ET tube mo. So that is, nag-leak out na, no? Kasi nga, wala na yung ET tube. So low pressure alarm. Very good. So these are the factors related to low versus high pressure alarm. Okay, job well done. In case nag-a-alarm yung mech vent mo, what is your priority action to take? Is it to check your mech vent or check your patient? So you hear the mechanical ventilator alarming daw, regardless whether high or low. Anong unang i-check mo? Yung mech vent, yung patient. Patient first. Very good. So always remember, so we have to check the patient first. And before you check your mech vent, you have to stabilize first yung breathing ng patient. Because take note, The fact na naka-MEC-vent yung client mo, kailangan niya ng support sa paghinga. So your main goal is to assess the patient, check kung okay ang respiratory effort niya, kung okay ang respiratory function niya. So you see your client is in respiratory distress. So before you check your MEC-vent, so you hook your client to ambu bag. Okay, kaya nga kapag naka-MEC-vent, laging may ambu bag. So stabilize your patient's breathing through the ambu bag. So once your patient's breathing is stabilized, that's the time you check the MEC-vent what's wrong kung hindi sa patient yung problema. Okay, so check your patient first. Kung yung patient, kung nasa patient yung cause ng alarm. Hindi mo nahanap sa patient yung cause, stabilize patient's breathing first. Pag okay naman si patient, so that's the time you check your MEC-vent. Very good. Okay, so that is for high versus low pressure alarm. Clear so far? Malinaw tayo? Yes. Okay, sige. So another common management for respiratory condition could be surgical approach. So with surgery, common natin naririnig yung term na lobectomy versus pneumonectomy. So what is the difference? Nasa pangalan na mismo. Lobectomy, ectomy is removal. Ano lang ni-remove pag lobectomy? So lobectomy is removal of a lobe only. Very good. So pwedeng upper lobe, lower lobe. Okay, so that is lobectomy. Post-lobectomy, commonly asked in the test, how do you position your patient post-lobectomy? Very good. Okay, so unaffected side. So for example, your patient is post right upper lobe lobectomy. Okay, so right upper lobectomy, how do you position? Right upper lobectomy. Paano mo ipoposition? So unaffected, so meaning left side lying. Okay, very good. Oh, naalala yung lupa, no? So common na mnemonic nyo yung lupa. So lobectomy, unaffected. So L for lobectomy, U for unaffected. Job well done. Do you expect patient will be hooked to chest tube? May CTT to ba? May drainage ba ito? NLE, oo. So NLE pa lang, no? Alam na natin to eh. Kaya wag nang kakalimutan to. Okay? So post-lobectomy, do you expect patient should be hooked on a CTT, chest tube? May CTT ba ito? To promote drainage from the post-op site. Merong CTT? Wala. Meron. Very good. So CTT is indicated to drain. Diba? So the blood from the post-op site. Okay, so drain the fluid in the blood from the post-op site, so CTT would be indicated. So remember, unaffected and expect CTT. As opposed to pneumonectomy. Pneumonectomy. So with pneumonectomy, pneumo. So removal of the entire side of a lung. So either removal of the left, removal of the right. Okay. Post-pneumonectomy, how do you position? So sabi nyo, NLE pa lang tinatanong na to, di ba? So dapat kabisadong-kabisado na affected. Very good. So letter P, pneumonectomy, affected. So affected side. Very good. So for example, your patient is post right pneumonectomy. How do you position right pneumonectomy? So patient undergone right pneumonectomy, paano ipoposition? Left side lying, right side lying. Right side, affected side. Very good. For what purpose? So to prevent the trachea from shifting into the empty side. So to prevent the trachea to shift onto the empty side. Kasi empty na yung isang side, no? So yung trachea mo na nasa midline, pwedeng mag-shift into the empty side. So you do not want that to happen kasi that will be a respiratory emergency. So to prevent tracheal deviation, at the same time promote re-expansion of the remaining good lung, okay? So we have to position affected side, okay? Post-pneumonectomy, do you expect CTT? Naka-chest tube ba ang patient natin post-pneumonectomy? Wala. Very good. So, hindi nagsi-CTT, hindi nagde-drain. For what purpose? Because we want to promote consolidation of the empty side para nga hindi mag-move yung trachea into the empty side. Okay, very good. So, yun yung difference nila. Okay, huwag kakalimutan. Lobectomy, unaffected, CTT expected. Pneumonectomy, affected side. Okay, no CTT expected post-procedure. So, that is lobectomy versus pneumonectomy. Clear tayo ha? So sabi nyo nga since NLE, kinabisado nyo na ito. So next, what are the possible complications of different lung surgeries? So one of which is KD, may question si KD? Sorry. Wait lang ah. Naubo lang. Okay, so question yung KD, yung sa lobectomy, it is expected for your patient to have a CTT. That is to promote drainage dun sa post-op site, diba? To promote re-expansion of the remaining lung kasi hindi naman lahat tinanggal. But post-pneumonectomy, no CTT would be indicated because our goal is to promote consolidation of the empty side para hindi mag-shift yung trachea into the empty side. Since empty na yung one side, tinanggal na yung isang buong lung, so yung trachea, may possibility na mag-shift, diba? Mag-deviate into the empty side. So we want to prevent that. So that's why usually no drainage would be placed para to promote consolidation of the empty side para hindi mag-shift yung trachea into the affected side. So what are possible complications post lung surgery? First, tracheal deviation as mentioned. Emergency to, no? So ideally, the trachea, hindi dapat yan nasa isang side lang. Dapat yan ay always at midline. So should be positioned at midline. So to prevent tracheal deviation, as mentioned a while ago, position your patient affected side post pneumonectomy. Okay? And also, another possible complication, atelectasis, lung collapse. So to prevent atelectasis post-lung surgeries, patient would be encouraged to engage with deep breathing and coughing exercise. So isa yan sa tinuturo natin for patients post-op. So to prevent atelectasis or lung collapse. And part of their lung exercise is the incentive spirometer. So later on, we'll be discussing the steps kung paano gamitin yung incentive spirometer. And for them to participate actively with deep breathing, coughing, and incentive spirometer, so make sure to treat pain as well. Because most common cause kung bakit ayaw nilang gumamit ng incentive spirometer, they do not want to participate with deep breathing and coughing exercise because they are so much in pain pa. So make sure whenever you want to try to encourage your client to participate with these activities, make sure to um, pre-medicate patient first. So relieve the pain. Okay, so you also teach your clients splinting. So whenever they're coughing, so splinting also to prevent excessive exertion that would cause more pain than to your patient. Another possible complication, shoulder ankylosis or frozen shoulder. So you encourage them arm exercises. So simple arm exercises and movement lang naman for 2 to 3 times a day. Kasi 'di ba, since they're in pain, so kaya part din ng management dito is treat their pain. Kasi kung bakit nila pinipigilan na gumalaw and huminga ng maayos, deep breathing, mag-coughing, kasi nga they are in pain. Okay? So that's why you have to treat the pain as well and encourage them to exercise, promote movement of the arms 2 to 3 times a day to prevent the frozen shoulder. So those are possible complications after a lung surgery. And as mentioned earlier, for a client post-lobectomy, so drainage will be expected. So drain the excess fluid and blood from the post-op site. And that is the chest tube drainage, CTT. So chest tube thoracostomy, so CTT. In CTT, we have 3 bottles. O, sa isa pang, since NLE, alam na alam nyo na, no? So the 3-way bottle system, what are the things we have to remember with the 3-way bottle system? So the first bottle, closest to your patient, that is the fluid collection bottle. In the fluid collection bottle, what should be normally expected? Normally, you expect that drainage should be less than 100 ml per hour. So normal drainage, less than 100 ml per hour. In terms of color, it is considered normal if the drainage is serous or serosanguinous. So pag nakita niyo yung color na serum, clear fluid, okay lang yon, expected lang yon. Kapag ang nadadrain naman is serosanguinous, combination of serum and blood, that's fine. That's normal. So what is reportable if the amount is excessive, more than 100 per hour, and at the same time if it's bright red in color? Because bright red discharge, that is a sign of active bleeding. So that is the one that is reportable. So too much and at the same time bright red in color, so that could be a sign of active bleeding. So that is reportable for the first bottle or the fluid collection bottle. Commonly asked in the examination, the second bottle, the water seal bottle. So with a water seal bottle, what should be normally observed in terms of bubbling? Ano ba ang normal bubbling noted sa water seal bottle? So with the second bottle, the water seal bottle, what would be the normal bubbling? It should be gentle. Very good. And not continuous, should be intermittent. Gentle, intermittent bubbling. If there is continuous bubbling, reportable yon. Okay? If there's continuous bubbling, what will you suspect is the cause of the continuous bubbling? Leakage. Very good. So it might be a sign of air leak, right? So definitely reportable. Paano naman kapag no bubbling? So no bubbling for a newly inserted pa lang. Newly inserted CTT, walang bubbling at all. Very good. You have to check for kinks or obstruction. Okay, so check for kinks or obstruction. Okay, double done. Paano naman pag, for example, hindi na newly inserted CTT yan. So for example, 3 days ago pa yan. Tapos, nawala na yung bubbling. Very good. That is correct, Arlene. So that might be a sign that the lung has re-expanded already. Okay, very good. So the chest tube drainage, so this will be used to promote drainage, diba, ng fluid, ng blood from a post-op site, at the same time to promote re-expansion, okay, of the affected lung as well. Very good. So kapag wala ng bubbling after few days of use of CTT, so that could be a good sign. So that is a sign na re-expanded na yung lungs. Okay, double done. So next, how about for the pressure regulator bottle, the third bottle? For the pressure regulator bottle, what would be the expected bubbling? So it is expected na may bubbling ba sa pressure regulator bottle or the suction bottle sa third bottle? Very good. Expected na yung continuous, pero gentle pa rin. So normal lang yung continuous pag suction or pressure regulator bottle. Pero kapag continuous sa water seal, reportable yon. So tatandaan ha, yung continuous bubbling okay lang sa pressure regulator bottle or suction bottle because that is due to the suction. But it should be gentle, not vigorous. Okay, because if it's vigorous, that might mean that the pressure or suction might be too high. Okay, so those are the normal versus abnormal findings in the three-way bottle system. Hot topic in the examination. If, for example, upon entering the client's room daw, you check the CTT, it was dislodged. What action to take? Or upon checking the CTT, it was disconnected. What action to take? So those are the common questions, right? So ngayon, pag nagkaroon ng dislodgement of the CTT, what action should you take? Dislodgement. Ano bang ibig sabihin pag na-dislodge yung CTT? So pag na-dislodge yung CTT, okay, meaning natanggal from the insertion site. Very good. So natanggal from your chest area. So very important, you have to cover, very good, the site. So remember, pag natanggal yung chest tube from your chest itself, open chest wall na yan. So makakapasok yung air from the open chest wall. So patient can be at risk for pneumothorax. So your main goal is to cover. So cover, okay, so you have to cover the insertion site, double done. So cover with a sterile petroleum gas, okay? So sterile gas, double done. So yun yung main goal. Pag dislodgement, that means from the insertion site. Paano naman pag disconnected? So pag ang term ay ginamit ay disconnected, so that means sa tubings lang. So pag nag-disconnect yung tubings, anong gagawin natin? So you have to simulate water seal pa rin. So i-immerse mo lang yung tip of the tube in a bottle of sterile water. So natanggal sa chest, cover the site. Okay, so na-disconnect yung tubing, just immerse the tip of the tube in a bottle of sterile water. Okay, so those are important management in case dislodgement or disconnection happen, commonly asked in the examination. Clear tayo dito? Kung walang sterile bottle, so for example sa options nyo, wala kang nakita na bottle of sterile water. So anyone na may water, so for example, may basin ka and then water, so the main goal lang is to simulate water seal. Ma-seal mo siya sa water. Okay? So ganun lang yung, so you could be resourceful in case kung wala ka man dyan. So the main goal is to simulate water seal. So for example, may basin ka, and then fill it with water, and then immerse. Ganun pa din. Okay? So that is our action to take in case dislodgement or disconnection occurs. Do not answer, okay? Do not answer clamp the tube. Kapag kunyari na disconnect, clamp it. So yung clamping, obsolete na siya. Kasi clamping can increase risk for pneumothorax. So we do not clamp the CTT unless clearly ordered by the doctor. So hindi tayo pwedeng mag-clamp ng walang doctor's order to decrease risk for pneumothorax, tension pneumothorax. Okay lang po sa bottled water, ma'am. Pwede, in case yun yung nasa option mo. Oo. So tatandaan nyo lang sa option, pag wala yung ideal, the ideal is bottle of sterile water. Kaya dapat lagi kang meron yan kapag may CTT yung client mo para may magamit ka during emergency. But in your examination, for example, walang binigay na ideal, the bottle sterile water. So hanap ka lang ng anything na parang sinasimulate yung water seal. So kung may bottled water ka, walang problema, Marjorie. Very good. So that could be a good option as well. So imaginein mo lang, sinasimulate mo lang din yung water seal. Okay? So that is for the chest tube. Clear tayo? Yes. Okay. So next, we have mentioned a while ago, to prevent atelectasis in a client who is post-operative, one activity that we encourage them is the use of incentive spirometer. Nakakita na kayo nito or naka-experience na ba kayong gumamit nito? So ba, common to for post-op client to prevent lung atelectasis, to prevent lung collapse, or to promote the expansion of the lungs, right? Nakakita na. Oo, okay. So with incentive spirometer, parang lung exercise to promote re-expansion of the lungs. So with here, common na lumalabas sa examination steps on how you teach your client the use of incentive spirometer. So first thing to do, you instruct your client upright position. So upright, so sitting or standing position, so at least semi-fowler, so elevated head of bed. And then instruct your client to put the mouthpiece, so in the mouth, so seal it in your mouth, and then instruct your client to slowly inhale. Okay, so anong gagawin? Breathe in air slowly. And then as you breathe in air, what you will notice, dapat makita mo na itong piston na to, itong color blue na to, tumaas up to your target. So for example, sabi ni the doctor, i-target mo na hanggang 2.5 yung ma-reach mo. So habang nagbe-breathe in ka into the device, so ito dapat umaakyat up to the target. Okay, so may goal marker ka dyan para alam mo kung hanggang saan dapat. So dapat umabot siya up to the target and then hold for at least 3 seconds yung breath mo dun sa target. And then after that, exhale. And then repeat it at least 10 times. Okay? So exhale and then repeat at least 10 times succession. So para siyang lung exercise to promote lung re-expansion. So initially, pwede mo naman simulan pa konti-konti. So hanggang 1,000 lang muna. And then pag nag-i-improve ka na, so madali na sa yung nare-reach yung 1,000. So the next time, increase it to 1.5 and then hanggang sa pinakamataas. So lang form of lung exercise siya to promote re-expansion of the lungs, prevent atelectasis or lung collapse. So yun yung tinatawag nating incentive spirometer. Clear tayo dito? Are we clear so far before we proceed with the different disorders of the heart, the lungs? Okay. Sige. So kung malinaw, so now let's begin with the different respiratory disorders. So first and commonly asked, COPD, chronic obstructive pulmonary disorder. So sometimes this is called as chronic obstructive lung disease or chronic airflow limitation. So COPD is progressive and irreversible. So it is something progressive and irreversible. So from the name itself, chronic. So progressive and irreversible. So risk factors that would aggravate or increase risk for COPD, smoking and exposure to different environmental pollutants. So with smoking, cigarette smoking and pollutants, so we have two types of COPD. We have chronic bronchitis versus emphysema. So with chronic bronchitis, ano bang nangyayari? There's due to smoking and environmental pollutants, so nagkakaroon ng hypersecretions of mucus and inflammation. Okay, so for example, this is your normal bronchi. So yun yung normal bronchi mo. So due to these factors, smoking, environmental pollutants, so there will be increased secretions of mucus and inflammation of the bronchi. So nagkakaroon ng thickening ng walls ng bronchi. So nagiging narrow na. So ito wide pa yung normal. Pero dahil nag-thicken, there's inflammation. So nag-narrow na yung airway mo and there's increased mucus production as well. So that's why there could be mucus plug. So yun yung nangyayari kay bronchitis. So this is chronic and progressive. as compared to emphysema. So with emphysema, so still related to smoking and environmental pollutants, what happens is this leads to the loss of the normal elasticity of the lungs. So due to the lack of the alpha-1 antitrypsin. So alpha-1 antitrypsin, so this is the one responsible for the normal elasticity of our lungs. So the elastin. So there will be loss of elastin. So yung elastin, ito yung responsible sa normal elasticity ng lung natin. Kaya you will notice when we, for example, pag nag-i-inhale tayo, our lungs are able to expand, 'di ba? So yung lungs natin nag-i-expand. And then when we exhale, our lungs are able to go back to its original state. Okay? Kasi dahil yan dyan sa normal elastin, normal elasticity ng lungs natin. But due to smoking and environmental pollutants, there's loss of elastin. There's deficiency of the antitrypsin factor that promotes the normal elasticity, thus leading to alveolar destruction, alveolar damage. So this is how your normal alveoli looks like. So there's normal elasticity. So able to expand dyan yung nangyayari yung gas exchange. But due to these factors, anong nangyari na damage yung alveoli natin? Okay, so there's alveolar damage. Kaya there's loss of the normal elasticity as well in a client with emphysema. So the two types of COPD, chronic bronchitis and emphysema. Okay, so chronic bronchitis and emphysema. So what are the signs and symptoms commonly noted for a client with COPD? So signs and symptoms, cough. Okay, so may ubo kasi may secretions, right? There could be exertional dyspnea. Mabilis silang mapagod, mabilis hingalin. So expected lang sa kanila yung exertional dyspnea. Wheezing. So wheezing due to bronchoconstriction, there's narrowing of the airway due to inflammation. There is crackles due to increased secretions as well. Okay, there's sputum production. So there could be weight loss. Barrel chest, yung barrel chest specific to emphysema due to the loss of the normal elasticity. So yung normally yung ating ratio ng chest is 1:2. So mas mahaba, 'di ba, yung transverse diameter. But due to the loss of the normal elasticity, nagkakaroon ng barrel chest appearance. Nagiging equal yung size ng anterior-posterior versus the transverse diameter of the chest. Kaya mukhang barrel, di ba? So barrel shape na yung chest. So that is common for emphysema due to the loss of elastin. Okay? So loss of elastin. Sige, no problem, Rafi. Pagtapas dito. Okay? Use of accessory muscles for breathing. Tatandaan nyo, pag makita mo yung use of accessory muscles for breathing for anyone with respiratory condition, this is already a late sign. Reportable sign yan. Okay? So late sign na yan, meaning in respiratory distress na yung patient mo. Our normal muscle for breathing is the diaphragm. Okay? Pag ginamit mo na yung sternocleidomastoid and trapezius muscles, meaning sobrang hirap ka ng huminga. So ginagamit mo lang yan pag in distress na ang patient natin. So airway compromise. So whenever you see accessory muscles for breathing, hindi yan basta expected lang. That is already a sign of airway compromise. Reportable na yan. Emergency yan. Okay? So there's hyperinflation seen on X-ray because since constricted yung airway natin, so there is inability to move in and move out yung air natin effectively. So there's trapping of the CO2, kaya hyperinflated din yung lungs natin. So this is how a normal X-ray looks like. This is how a hyperinflated lung in X-ray looks like. Okay? And since there's trapping of CO2, na-trap yung CO2, marami kang CO2 which is acid, marami kang respiratory acid. That's why the common arterial blood gas for a client with COPD, as we have discussed a while ago, respiratory acidosis. Okay, so in a client with COPD, so watch out for respiratory acidosis due to the trapping of CO2. Clear tayo sa mga symptoms na to? So tatandaan na pag gumagamit na ng accessory muscles for breathing, hindi yan basta expected. That is already a reportable sign, warning sign already. Sign of respiratory distress. Clear tayo for the signs and symptoms? Yes? Okay, balik lang ako sa previous slide ha. Ito, Rafi. So, two types of COPD, chronic bronchitis, emphysema. Parehong progressive and irreversible. Okay, so progressive and irreversible. So with bronchitis, So inflammation of the bronchi, kaya may narrowing and increased secretions as well. So there's inflammation and there's increased mucus production with emphysema, destruction of the alveoli. So what is our management? Okay, so I summarize it with the mnemonic COPD. Letter C, since my secretions, chest physiotherapy to move out the secretions. So another letter C, use of corticosteroid because there is bakit kailangan ng corticosteroid? May inflammation, 'di ba? To act as an anti-inflammatory. Bronchodilator. So bronchodilator to promote bronchodilation. Okay? Example ng accessory muscles. So yung example natin, ito yung sternocleidomastoid, yung tinatawag nating accessory muscles for breathing. That is the sternocleidomastoid. Okay, so sternocleido, di ako sure sa spelling. Basta sternocleidomastoid and also the trapezius. Okay, so the trapezius muscle. So yung sternocleidomastoid dito. Okay, so sternocleidomastoid and then trapezius muscles dito sa back. Okay, so yan yung mga accessory muscles. Normal muscle lang natin for breathing, diaphragm, 'di ba? So yun yung ginagamit natin for breathing normally. Pero pag ginagamit mo na ang sternocleidomastoid tsaka trapezius muscles, so those are signs of respiratory distress already. Ayan, tama. Sorry naman sa spelling ko. Sternocleido, kulang ng ayun. So sternocleidomastoid. Okay? Thank you very much, Kimmy, for the help. Okay, so now those for corticosteroids to act as an anti-inflammatory bronchodilator. Okay, to promote bronchodilation kasi nga may bronchoconstriction, right? Constricted airway. So additionally, conserve energy. Sabi natin kanina may exertional dyspnea, 'di ba? Mabilis mapagod, mabilis hingalin. So we want to conserve their energy. So whenever you are serving food to them, small frequent feeding, no? So small frequent feeding tayo. Okay, so small frequent feeding. And in terms of questions, whenever you ask them questions, close-ended question. Okay, kasi nga mabilis silang mapagod, wag mo nang pag-rationalize. Explain in 50 sentences. Ay, no, pinagod mo pa siya. 'Di ba? So close-ended question meaning answerable by yes or no. So pang psych client yung open-ended question. So kay COPD, okay tayo sa close-ended question kasi nga mabilis silang mapagod. So wag mo nang pag-explain pa yan ng rationale. Okay? So next, O2. So with O2, we keep giving O2 to them at low level of oxygen only. So low flow O2, 2 liters per minute via nasal cannula. Bakit nililimit natin yung pagbibigay ng oxygen for a client with COPD? Why can't we give too much oxygen? Why can't we give high level of oxygen to them? They will drown. Very good. Hypoxic drive. Exactly. Okay, so that they will not lose the hypoxic drive. Exactly. In a normal person without COPD, for example, tayo, wala tayong COPD. What signals our body to breathe normally is the increase in CO2. Okay, yung nagsisignal sa katawan natin para maghuminga properly and normally, the increased CO2. In a client with COPD, okay, what signals them to breathe is what? The decrease in oxygen. So abnormal, no? So what signals them to breathe is the decrease in oxygen. So imagine, if you give them too much oxygen, is it as if telling their body not to breathe anymore? Since ang nagsisignal sa katawan nilang mag-breathe is low O2, so kapag binigyan mo sila ng too much oxygen, so para mong sinabi sa katawan nila na wag na silang huminga. Kaya risk for respiratory depression kapag binigyan mo sila ng too much oxygen. Very good. So kaya very careful tayo when giving or administering oxygen in a client with COPD. So in relationship to the hypoxic drive. Very good. So limit oxygen. So usually ideal 2 liters per minute. Okay? And expect mo, so for example, yung O2 sat ng client mo na may COPD, 90%, 92%, 89%. Reportable na ba agad yon? Expected lang. Very good. That is normal and expected for them. So 88 to 92% usual O2 sat ng mga may COPD. So do not expect them na talagang 100% sila. So expected lang yon. Very good. So not naman reportable agad. So for them to have saturation of 88 to 92%, actually yun usually mini-maintain. to prevent hypoxia and prevent hypercapnia. So 88 to 92 is just expected for someone with COPD. Job well done, everyone. So next letter O, to maximize breathing effort, orthopnic position, just like in the picture. So sitting up, leaning forward. Okay, so to maximize their breathing. So especially if nahihirapan silang huminga, so encourage orthopnic position or high Fowler's position. Okay, so high Fowler's position. Pursed lip breathing. So pursed lip breathing, why do you teach them pursed lip breathing? What is the purpose? Paano ba yung pursed lip? So you instruct your client to breathe in through the nose and then exhale through the mouth with the pursed lip. Okay? And usually prolong din yung exhalation. So yun yung pursed lip. Why do you teach a client with COPD to do pursed lip breathing? Excuse me. What is the advantage? Exactly, Arlene. So that helps to eliminate the excess CO2, to blow off the excess CO2, right? Since a client with COPD has trapping of the CO2, kaya nga sila for respiratory acidosis, so you want to help eliminate the excess CO2, you encourage them pursed lip breathing. Very good. So that is to eliminate or blow off the excess carbon dioxide. Job well done. In terms of diet, we have to limit carbs. Their energy will be coming from protein. So high calorie, high protein. So their energy cannot come from carbohydrate. Why? Bakit hindi pwedeng mag-high carb diet pag COPD? Bakit protein ang source of energy nila? So may easy fatigability sila, they have activity intolerance, but their energy will be coming from protein, not from carbohydrates. Exactly, Arlene, because the more carbohydrates you take, the more CO2 you produce. Because one byproduct of CO2 or one byproduct of carbohydrate breakdown is carbon dioxide as well, CO2. So the more carbs you take, the more CO2 you produce. Since sobra na nga tayo sa CO2 kay COPD, ayaw pa natin magdagdag more, right? So we limit the CO2 production by limiting carb intake as well. Okay, very good. So those are important management for client with COPD. Malinaw tayo dito. So COPD, emphysema, and your chronic bronchitis. Thank you, Arlene, for acknowledging. How about for the rest? Are we clear? Malinaw tayo sa COPD. So the main picture with COPD, there's trapping of CO2. There's bronchoconstriction. That's why there's trapping of CO2. Risk for respiratory acidosis. Okay, thank you very much everyone for acknowledging. So i-compare natin kay asthma. So with asthma, si asthma, bakit siya hindi classified under COPD? Kasi si asthma is reversible. Okay, reversible. Actually, many years ago, si asthma dati classified pa yan under COPD. Pero tinanggal nga siya as part of COPD kasi hindi naman siya irreversible. Siya ay reversible. Yung symptoms kasi ng asthma, parang bronchitis din. So almost same with bronchitis. May inflammation, may bronchoconstriction, and may increased mucus production. So same symptom, no? However, asthma is reversible. So that's why it was not classified already as COPD. So it is reversible. What triggers asthma? Ano ba yung mga common trigger ng asthma natin? Allergens. So allergens can be something internal or something external. Okay? So internal pwedeng trigger, like for example, stressor. Physical stress, emotional stress can be both trigger of asthma attack. Extremes of emotion. You are too happy. You are too sad. You become too excited. Pwede bang makatrigger ng asthma attack? Pwede bang makatrigger ng asthma attack yon? Extremes of emotion. Yes, no, very good. 'Di ba kaya kapag may asthma, we avoid then extremes of emotion. Okay? We avoid extreme sadness, extreme happiness. Okay? Parang makaka-trigger ng asthma attack 'yon. So, emotional stress 'yon. And aside from emotional stress or physical exhaustion could be a trigger of asthma attack din. So, in terms of exercise, regular exercise, okay lang 'yon. Good for the lungs pa 'yon, can strengthen your respiratory system. But strenuous or excessive or vigorous exercise, sobra-sobra exercise, so that is physical exhaustion. So that could be physical stress. That could be a trigger. Infection, irritants. Okay, infection, so that could trigger, that could also be a trigger. Aside from that, irritants, so any irritants, any external irritants, like for example, yung mga allergens natin could be pollens, okay, pwedeng food, 'Diba? So there are allergens like nuts and chocolates. So common allergens yung mga yon. So anything that can cause irritation and allergic reaction. And one part of that is MSG, monosodium glutamate. So that could be an irritant and allergen as well. With this allergic response, anong mangyayari? So lalabas, release of these substances such as IgE, mast cells, histamine, and leukotriene. So all as a result of allergic response. So release of these substances. Kaya mapapansin nyo, when we proceed to medication for asthma, ano ba yung mga gamot natin for asthma? Antihistamine, leukotriene modifiers, mast cell stabilizers, diba? So related sa mga release na ito. So all related to allergic response. So we are trying to alter the release of these substances. And with these substances, this causes the bronchial constriction, the mucosal edema, and increased mucus secretion. Kaya sabi natin kanina parang bronchitis din, di ba? So nagkaroon ng bronchial constriction. So there is inflammation and edema of the mucosa, and there's increased mucus production. So almost the same picture as bronchitis. It's just that in bronchitis, it's progressive and irreversible. With asthma, it is reversible. So yun yung difference nila. Okay, but almost same picture, almost same symptom. And with these, if this progress, eventually it could lead to airway obstruction, hypoxemia, airway trapping, kaya may CO2 trapping din. So that's why kanina in-emphasize natin, early stage of asthma attack, pwedeng hyperventilating pa yung client mo kasi trying to compensate pa. But pag totally constricted na yung airway, so natatrap na din yung CO2, just like with COPD. Kaya risk for respiratory acidosis as well. Okay? So that is the pathophysiology of asthma. Clear tayo dito? So same may constriction, mucosal edema, and secretions, almost same like with bronchitis. It's just that this is reversible. Malinaw. Thank you, Jean, for acknowledging. So what will be the symptoms? So you will notice the symptoms are almost the same with COPD, diba? So parang same lang. So sabi ko kanina, pag may accessory muscles used already, and then that is a late sign na. Okay, so that is reportable na. So very important to remember with asthma, almost same symptoms as COPD kasi may bronchoconstriction. So very important to note kung early or late yan. Pag early stage of asthma, as we have mentioned a while ago, pwedeng takipnik pa yung client. Okay, kaya risk for what? Acid-base imbalance, respiratory acidosis, alkalosis. So kapag early stage, since takipnik pa yung client natin, alka pa. Very good. Pero pag totally constricted na yung airway, so there will be absent, diminished lung sounds and breath sounds already. So now, patient becomes risk for respiratory acidosis. So watch out for absent breath sounds in a client with asthma. So that could be a warning sign of constricted airway already. Totally constricted airway na. So risk for respiratory acidosis. So natatrap na yung CO2. So unable to move in and out air effectively. Job well done. Okay, no problem, Zon. Sige, balik ko sa previous slide. Okay, so that's for asthma. So with allergic response, so different allergens, different triggers, stress, infection. So this triggers allergic response. So thus leading to constricted airway, mucosal edema, and increased secretions. And eventually, worst case scenario, pwede rin magkaroon ng respiratory acidosis. So due to trapping of CO2. Okay na. Sige. Okay, so how about this one? Okay tayo dito. So are we clear with the symptoms for asthma? So same symptoms. So just take note, kapag early, risk for respiratory alka, pag late, respiratory acidosis. One common test na ginagawa natin for asthmatic patient, any one of you with asthma, meron ba sa inyong with asthma? Very familiar kayo kung meron man kayo nito, no? So, peak flow meter. Yung peak flow meter, this is used for a client with asthma to check for effectiveness of treatment regimen and usually to check rin kung worsening yung symptoms ng client mo. So with the peak flow meter, steps on how to use this one. So instruct your client to move the indicator, dapat nasa 0. So sa pinakamababa. And then, upright position pa rin. So standing up or sitting down. And then, instruct your client to take a deep breath to fill in your lungs. first and then put the mouthpiece into your mouth. So seal it in your mouth. After that, you instruct your client to blow hard and fast in a single blow. Okay, so blow in a single blow, hard and fast. And as you blow, the indicator should go up. So ito, pag nag-blow ka, dapat aakyat the highest possible. So you will notice may mga color coding dito. So yung pinakamataas, green, that is the green zone. The middle part, that is the yellow zone. And the lower part, that is the red zone. So ideally, kung well-controlled ang symptoms ng client with asthma, so the patient should be able to reach the green zone. Safe zone tayo doon. Pag nandoon sa taas, sa green zone. Okay? So meaning, well-controlled ang symptoms ng patient natin, effective naman yung current treatment regimen niya. So that is the green zone. Pag si patient mo, na-reach lang yung yellow zone sa middle part, so that might mean that the patient is currently having symptoms of asthma attack. Okay? So usually pag yellow zone lang yung nare-reach ng patient natin, so patient would be given albuterol, the fast-acting bronchodilator, okay, to relieve the symptoms of asthma. Kapag ang nare-reach ng patient mo ay the red zone lang, the danger zone. So doon lang sa red, sa baba. So meaning severely. Okay? So severe yung symptoms ng client mo. So apart from the albuterol, patient would actually be given corticosteroid. Okay, so si patient bibigyan ng corticosteroid. So ideally, pag na-peak flow meter para masabing well-controlled ang symptoms and effective ang current maintenance medications mo, dapat nandoon ka sa taas. Okay, so the green zone or the safe zone. Okay, so that is the use of the peak flow meter to check for effectiveness of treatment regimen at the same time also to check for the severity of signs and symptoms of your client for a client with asthma. So peak flow meter. So what are the common management for a client with asthma? So management natin, I summarize it with the pneumonic asthma pa rin. Letter A, fast-acting bronchodilator. You receive a client having acute asthma attack. What is your priority medication to give? Albuterol. Okay, so albuterol, this is the quick relief medication. This is a fast-acting bronchodilator. So fast-acting bronchodilator yan. So kaya with acute asthma attack, ito yung initially binibigay natin. Albuterol. So most common medication given. So also, letter S, start oxygen as ordered as needed for your patient. And letter S as well, stay with the client to decrease anxiety. So do not leave your client. Letter T, tell your client to avoid triggers already. So avoid yung physical exhaustion, emotional stress, other external triggers. So make sure to avoid anything that triggers asthma attack, allergens. Position your client high fowlers to maximize breathing effort. So basta nahihirapan ng huminga, elevate head of bed, diba? So high fowlers or top neck position. So those are good to maximize breathing effort. Letter M, what are the common medications given to your client with asthma apart from albuterol? Since may bronchoconstriction, expect giving bronchodilators. So bronchodilators, usually via inhalation. Corticosteroids, diba? So steroids to act as an anti-inflammatory kasi may airway inflammation as well, diba? May bronchial inflammation. Mast cell stabilizer because mast cells, sabi natin, kasama yan doon sa allergic response. So with the release of mast cells, nagkakaroon ng bronchial inflammation. So nagbibigay ng mast cell stabilizers. Common example of mast cell stabilizer, we have the cromolyn and nedocromil. So common example niyan, si cromolyn and nedocromil. Okay, so usually via inhalation din. And more of maintenance medication siya. Leukotriene modifiers. Familiar kayo sa leukotriene modifiers? Very good, JR. Yung mga ending with Lucas. Montelukast. So more of maintenance medication din, no? So Montelukast, Zaferlukast. So yung mga ending with Lucas. How about xanthin derivative? So xanthin derivative, ano naman mga example nito? Ito naman yung mga ending with Philin. Naalala niyo yon? Theophylline, okay, aminophylline. In hot topic in the examination regarding mga phylline, this has narrow therapeutic level. Ano yung therapeutic level kapag mga phylline? Theophylline, aminophylline. Okay, so narrow therapeutic level, maintain 10 to 20, very good. So 10 to 20 mcg per ml. Okay, very good. So this has narrow therapeutic level. So tatandaan yan. So those are medications given for client with asthma, apart from the fast-acting bronchodilator, albuterol. So during acute attack of asthma, yung priority drug natin, albuterol. So other medications, so especially yung mga mast cell stabilizers, leukotriene modifiers, more of maintenance medication sila. So next we have letter A. So of course, especially if you give medication to your client, so auscultation is very important para malaman natin kung effective na yung gamot. So auscultate before para may basis ka, during, and then after treatment regimen. Okay, so check for improvement of the breath sound. So especially most common symptom with asthma, as mentioned a while ago, wheezing. 'Di ba? So alam mo na kapag nagbigay ka ng bronchodilator, dapat nare-relieve yung wheezing ng client natin. Okay? So most common symptom in a client with asthma, wheezing. So when you see wheezing, you know airway is constricted. So that is for asthma. So the difference with asthma and also your COPD, asthma is reversible. So almost same symptom. Si bronchitis tsaka si asthma, parehong may bronchial inflammation, may constriction, at increased mucus production. It's just that in asthma, it is something reversible. So another common medication indicated for a client with asthma, the meter dose inhaler, MDI. Hot topic in the examination regarding MDI, steps sa paggamit ng MDI. Okay? So how do we use a meter dose inhaler? So first step, remove the cover. Okay, so remove the cover of the meter dose inhaler and then hold it upright. Shake. Okay, and then stand up or upright position. So sitting up or standing up, so basta upright position. So instruct your client to breathe out slowly first, to empty yung lungs mo para ma-maximize mo yung pag-inhale ng gamot. So breathe out first and then prepare na yung inhaler mo in your mouth. So we have two ways to hold the meter dose inhaler. So pwede open mouth technique or the closed mouth technique. So with the open mouth technique, so place the meter dose inhaler 2 finger widths away from the lips. So 2 finger widths, so that would be mga 1 to 2 inches. So pag sinabi natin 2 finger widths, 1 to 2 inches, or that is 2 to 4 cm away. Okay, so away from the lips. So that would be the open mouth method. So meron din naman na closed mouth method wherein you will seal it into your mouth. So especially kung may spacer siya. And then, so once you're ready na, okay, so nandyan na sa may mouth mo, sa harap na ng mouth mo yung inhaler. So that's the time you're ready to activate the meter dose inhaler. So when you press it, when you activate it, begin to slowly breathe in na. Okay, to maximize inhalation of the medication. And so breathe in until your full breath. Hold your breath for at least 10 seconds to allow distribution all throughout your lungs. So after 10 seconds, so that's the time you fully exhale. So after exhaling, you can repeat a second puff, but wait for at least 1 to 2 minutes apart. Okay, so usually kasi 2 puffs yung indicated, di ba? Per dosage. So for example, after the first puff, wait at least 1 minute. So 1 to 2 minutes and then ulit lang ulit, second puff. So cover, put back the cover, and lastly, rinse mouth, especially if using a corticosteroid containing inhaler. Bakit importante? Hot topic in the test. Why is it important to rinse mouth after a use of corticosteroid containing meter dose inhaler? Bakit importante yung rinsing mouth? Very good. To prevent oral thrush. So, di ba, risk for oral candidiasis. That's why very important is to rinse mouth after a use of a meter dose inhaler containing especially corticosteroid. So, yung corticosteroid containing usually yung mga ending with zone. Fluticasone, okay, beclometasone, di ba? Okay, yung Seretide, yung most common brand name natin, di ba, yung Seretide, Pulmicort, Symbicort, so yung mga yon. So, those are corticosteroid containing. So to prevent risk of oral candidiasis or oral thrush, very good. So we have to rinse mouth after the use of it. So that is the proper use of a meter dose inhaler. So those are the steps. So be familiar with that. Sometimes this comes out as a drag and drop method or the ordered response. So you will arrange the steps. Clear tayo dito? Any questions, any clarifications from what we have discussed so far? None naman. Okay. Sige, if no questions so far, let's have a break, 15 minutes break. It's almost 8. Be back 8:15 and then we'll continue with the rest of our discussion. See you in a while. Thank you very much. Yes, Eunice. Yung mga corticosteroid containing usually are the ones ending with son. So fluticasone, beclometasone, yun yung mga common. Sige. Thank you as well. So see you in a while. Thank you very much, everyone. Hello, everyone. Ready to continue? Thumbs up if ready na. Thank you, Angelica. Okay, thank you everyone for acknowledging. So let's continue with our discussion. We're done with COPD and asthma. So now let's proceed to the different respiratory infections. Thank you, Laurelie. Thank you, Giovanni. So first we have pneumonia. So another common respiratory infection. So with pneumonia, this is infection that affects the pulmonary tissues, interstitial spaces, alveoli in the bronchiole. So usually affecting the lower respiratory tract. So this is inflammation of the lung parenchyma. It can be considered community acquired or hospital acquired. Pag sinabi natin o community acquired, meaning symptoms occur less than, paano natin masasabing community acquired? If symptoms occur less than 48 hours from confinement. No? If symptoms occur less than 48 hours from confinement or from admission. Versus kapag sinabi naman nating hospital acquired, so meaning symptoms started more than 48 hours. Okay, so symptoms occur more than 48 hours from confinement. So more than 48 hours from confinement or admission. Meron din tayong tinatawag kanina, nabanggit nyo yung ventilator-associated pneumonia. Pag VAP naman, ventilator-associated pneumonia, so usually, if symptoms occur more than 48 hours, so 48 hours, if symptoms of pneumonia occurs, 48 hours from intubation. Okay, so after 48 hours from intubation, nag-develop ng pneumonia, so that can be noted as ventilator-associated pneumonia. So with pneumonia, what are the common signs and symptoms? So common symptoms could be summarized with a mnemonic sputum. Okay, so sinummarize ko siya as sputum. So letter S, of course, are sputum production. In the sputum, usually description of a client with pneumonia, it is rusty, rust-colored in sputum. There's pleuritic chest pain, namamaga yung lung parenchyma. So if there's inflammation of the lung parenchyma, when you inhale, it would be painful. So yan yung tinatawag nating chest pain during inhalation. So chest pain during inhalation or inspiration. So that is the pleuritic chest pain. So use of accessory muscles as well. Worst case scenario, so usually more of a late sign for severe cases of pneumonia. Tachypnea. Increased temperature. This is infection related, so we expect fever. So usually fever, high-grade fever with chills. Mental status changes, so more of a late sign as well kapag may hypoxia involved na. Okay, so that is for pneumonia. Most common symptom for pneumonia, rusty sputum, the pleuritic chest pain, fever with chills. Diba? So yun yung pinaka-common symptoms. Rusty sputum, pleuritic chest pain, the high-grade fever with chills. So what management do we expect for a client with pneumonia? So pag may pneumonia, management natin, of course, treating the problems, right? So letter P, may secretions tayo, chest physiotherapy, and suctioning as necessary as well for the secretions. So letter E, to maximize breathing effort of your patient, elevate head of bed pa rin, at least semi-Fowler. So basta may problem with breathing, elevate head of bed para to maximize your breathing effort. So encourage fluids up to 3 liters per day as well to promote expulsion of the secretions. Also, we have high fiber or high calorie, high protein diet. Okay, so encourage high calorie, high protein diet. So small frequent feeding to serve as their source of energy. And in terms of medication, ano ba yung mga gamot natin? Infection related, so expect antibiotics. May fever, antipyretics. There could be, so we could give bronchodilators as well, mucolytic agents. So mucolytic, their secretions to promote expulsion of secretions. So mucolytic like ambroxol, okay, so flumicin, so to break up the mucus. And we have the expectorant, oo, NAC, di ba? So fluomacil, yun common natin. So yung flumacil ha, wag ipapainom ng buo. Nakakita na kayo nun? Familiar kayo? So yung fluomacil, 'di ba, the NAC, so wag ipapainom ng buo, 'di ba? Nung first time na Nakita mo yon, no? So, pinainom mo kay patient, "Nurse, ganyan ba talaga kalaki yan? Ilulunukin ko ba yan?" 'Di ba? So, ikaw na hindi ka familiar, "Yes po, ganyan po talaga kalaki yan, eh. So, lunukin niyo na lang." So, yun pala, very good, KD, effervescent, 'no? Naalala niyo yun, na-experience niyo yung mga gano'ng moment niyo. Tapos bigla mong na-realize na nakita mo yung kapwa mo nurse nagpe-prepare, dinesolve niya sa tubig yung kanya, ta's ikaw pinalunok mo, oh, 'di ba? Oo, so may mga gano'ng scenario, 'di ba? Okay, so at least learning experience. Nagbula yung bibig, JR, 'no? Nagulat ka, effervescent pala 'yun. Okay, so 'yan common na, mucolytic agent. So we also have the expectorant. So expectorant, yung guaifenesin natin to help clear the mucus as well, especially for productive cough. So letter O, give oxygen as ordered and as needed for your client. Okay, so generally, mapapansin nyo, pag may problem with breathing, ganun pa rin, elevate head of bed to maximize breathing effort. Okay, so that is pneumonia. So inflammation of the lung parenchyma. So most common symptom, rusty sputum, pleuritic chest pain, high-grade fever with chills. So in comparison to TB, so madalas na question in the examination, tuberculosis. With TB, this is airborne in terms of transmission. So considering this is airborne, what type of room should you admit your client into? Anong room ang kailangan natin for this client? Perfect. Negative pressure, private room. Okay, so negative pressure, private room dapat. You are caring for this client, what PPE should you wear prior to entering the room? Anong PPE yung susuotin? N95. Very good. So pag di mo nakita yung N95, you can look for HEPA filter mask. Okay, so HEPA filter or the particulate mask. Okay, very good. So yung mga respirator, specific respirator mask. So particulate mask. N95, HEPA filter mask, particulate mask. So those are the specific masks that could be used for a client with TB. Hot topic to sa examination. Natanong dati sa exam, you are caring for a client with TB, which precaution should you initiate? Memorize na memorize mo. Airborne ito. So ito yung pinaka-common na memorize natin na airborne condition, no? Lumabas dati sa examination, kaso wala yung airborne sa option. Okay, walang airborne sa option. Ang lumabas lang na option is droplet, contact, enteric, standard. So which precaution should you initiate daw for a client with TB? Droplet, contact, enteric, standard. Wala yung airborne na memorize mo. Anong isasagot mo sa option na binigay? Can we answer droplet? Yung droplet, yung airborne ba pwedeng maging droplet na lang? Magkaiba yon, no? Pag droplet, surgical mask would be good enough. Eh, hindi enough yung surgical mask para sa TB. So, TB cannot be droplet. Very good. Standard. Is standard applicable to all conditions? Applicable to all? Yes, di ba? Tatandaan nyo. So, in terms of infection control, standard is the tier 1 of infection control. Applicable to all condition. Yung airborne, yung droplet, yung contact are all under standard precaution. Yung enteric is a specific contact precaution na fecal oral route. Exactly, Laurelie, umbrella technique. So lahat ng ito pwedeng under standard precaution. So you can answer standard. So kung select all that apply yan, so you can choose standard and airborne. So wala yung airborne, you can choose standard. So for any condition, we can choose standard. Very good. Umbrella technique. So ganun siya tinanong sa exam before. So do not answer droplet for TB because TB is airborne. It cannot be droplet. Okay, so but standard, yes, that is correct naman, applicable to all. Job well done. So what are the common signs and symptoms noted for a client with TB? So of course, may ubo pa rin. Cough. So persistent, usually na cough. There could be chest tightness and dull aching chest pain, chills, lethargy. Okay, so lethargy, low-grade fever. So in comparison to pneumonia, for pneumonia, more of high-grade fever and chills. So kapag TB, more of low-grade fever. So low-grade fever, night sweats, yan common yan sa kanya. So sweats at night. Anorexia, so their sputum usually described as mucoid, mucopurulent, and more commonly blood tinge, blood streak sputum. And there could be hemoptysis, coughing out of blood. So that is for tuberculosis. So most common symptom dito, yung ating low-grade fever and night sweats, in the blood-tinged sputum, hemoptysis. So yun yung mga most common symptom in a client with TB. So huwag kakalimutan, airborne. Okay, and yes, generally, it could be standard as well. So proper PPE, N95 HEPA filter mask, particulate mask, and should be in a negative pressure private room. So what are the common diagnostic tests used for TB? We have the Manto test, we have the X-ray, we have the sputum AFB. Among these diagnostic tests, which would confirm, which will the confirmatory test? Alin yung confirmatory test para masabing may active TB ka? So which among these diagnostic tests would confirm positive TB? Very good. Sputum, no? So sputum culture, sputum AFB. So take note, Manto test and X-ray, hindi confirmatory test yan. So they are diagnostic tests just as additional, but it would not confirm yet kung positive ka na for TB, kung may active TB ka. Okay? So what would confirm that? Sputum talaga, sputum AFB. Very good. So Manto test usually more of checking for exposure to TB, diba? So exposure. So with Manto test, it is also called as the tuberculin skin test. Okay, so tinatawag din siya na tuberculin um, skin test or the Manto test. With the Manto test, so parang mag-i-inject, okay? So mag-i-inject na sa intradermal site, okay? And then after 48 to 72 hours, so after 48 to 72 hours, so it will be checked for wheal formation. So i-check yung size ng wheal formation, okay? So PPD, very good. So another common, aside from tuberculin skin test, is PPD, the purified protein derivative. Okay, that is correct. Yes, pwede din yung IGRA. O, sige, banggitin natin yung IGRA mamaya, JR. Okay, so with the Manto test, commonly kasi yung IGRA, yan yung mas madalas na ginagamit na today. So para din siyang Manto test, but more of blood test siya, 'di ba? So checking for exposure din. So with the Manto test, so tuberculin skin test, PPD or positive protein derivative, mag-i-inject ng uh, sa intradermal and then will formation will be checked after 48 to 72 hours. And after 48 to 72 hours, so pag chinek ni doctor, yung wheal formation is more than 10. So kailan natin masasabi na positive Manto test? Kapag yung wheal formation is more than 10 millimeter induration for an immunocompetent patient. Pag sinabi nating immunocompetent patient, healthy person, so not immunocompromised. Okay? So more than 10 millimeter induration is considered positive. However, yung mga immunocompromised client natin is usually at risk to have false negative result. Okay, pwedeng mag-false negative. Bakit? Pag nag-PPD ka sa kanila, so expected na hindi aabot ng more than 10. So kung hindi umabot ng more than 10, so pwedeng mo ma-count yun as negative result. Pero pag immunosuppress, false negative yun. Kasi expected lang sa kanilang hindi umabot ng 10. Kaya kapag immunosuppress, iba yung measure natin. At least more than 5 millimeter is already considered a positive tuberculin skin test for immunosuppress. Okay, so for immunosuppress. So, kaya tatandaan, pag immunocompetent healthy person, more than 10 is the measure. Pag immunocompromised, basta mag more than 5 na yan, considered a positive tuberculin skin test na. So, not yet confirmatory for TB. So, could be more of exposure to TB. And yung nabanggit ni JR, usually alternative to this, and mas common na ginagamit na nowadays in the laboratory, more of the IGRA. So, with the IGRA, or the usually ano bang meaning nito? Interferon gamma release. Okay, so ang meaning niyan, so interferon gamma release assay. Okay, so the IGRA, ito blood test naman siya. Okay, so blood test to check for exposure din siya with TB. So hindi rin siya confirmatory. Confirmatory still would be the sputum. So kung mag-positive yung IGRA mo, so that means may possible exposure ka, so or latent TB, not confirmatory for active TB. X-ray. So X-ray, ganun din. It cannot confirm TB yet. So makikita lang yung mga lung infiltrates in the X-ray. So our confirmatory test still will be sputum AFP. Okay? So with sputum AFP, what will be necessary? So usually with sputum AFB, 3 consecutive mornings. It is taken 3 consecutive mornings. Before I left Philippines, before mag-positive ako sa Manto test, sobrang kabado. Pero nung nag-x-ray dito, blood test, yes, oh, exactly. Madalas sa for UAE, no, IGRA yung ginagamit. Okay? So yun, kasi usually dito naman sa kasi dito, 'pag dito sa Philippines, madalas kasi mataas yung chances natin na mag-positive sa Manto test, tsaka even sa IGRA sometimes. Kasi nga, yung country natin is mataas yung cases ng tuberculosis. Kaya common yan sa atin talaga. Okay? So, going back to sputum culture, so with taken 3 consecutive mornings siya. Okay? So, 3 consecutive mornings. Tinanong ka ng patient mo, "Nurse, can I rinse my mouth with water?" Water lang naman. "Before you take my sputum." Okay lang ba yon? Yes, very good. Water lang, no problem. Okay? So water lang, wala tayong problema, okay naman 'yon. Paano kapag sabi ng patient mo, "Nurse, nakakahiya naman sa'yo, kakagising ko lang, eh." Kasi usually that is collected first thing in the morning, 'di ba? So first thing in the morning, and then sabi sa'yo ng patient mo, "Nurse, nakakahiya kasi sa'yo, eh. Puwede bang mag-toothbrush muna ako, mag-mouthwash muna ako." So do you think, that would be okay? Hindi na. So avoid any commercial mouthwash or any commercialized solution. So toothbrush, mouthwash, water lang will be fine, but anything with alcohol-based solution, so that could alter accuracy of the result. So definitely not allowed. So 3 consecutive mornings, first thing in the morning, so yun yung gagawin. So with the sputum AFB. And this is the confirmatory test. Okay, so this is the confirmatory test. So the X-ray, the Manto test, hindi naman yan confirmatory. With TB genotyping, so usually more of ano eh, so from the name itself, genotyping, so more of the genetic material nung mycobacterium, so yung tinitingnan. So with the genotyping, so genetics. So laboratory-based procedure din na more of yung genetic material nung Mycobacterium tuberculosis. So causative agent for TB, so Mycobacterium tuberculosis. So yung ginagamit natin confirmatory, so that is the sputum AFP. Okay? So clear tayo dito? So next, we have the TB meds. So with TB medications naman, usually that is summarized within mnemonic RIPES. So rifampicin, isoniazid, pyrazinamide, ethambutol, streptomycin. So there are common side effects that could be related to these medications. So tingnan natin kung familiar kayo. So ngayon, punta muna tayo dun sa optic neuritis. So which TB medication is commonly associated with optic neuritis. Alin dito ang nagkakos ng optic neuritis? Very good. So optic, letter E, eyes, ethambutol. Double done. How about red-orange urine? Okay, red-orange urine. Kanino common side effect ito? So pag nagre-rifampicin, expected lang na magkaroon ng red discoloration of the urine. Peripheral neuritis. Peripheral neuritis is very good related to isoniazid. And that is due to, actually, that is related to what? Pyridoxine deficiency. So, related siya sa pyridoxine deficiency. So, B6. Okay, so related siya sa pyridoxine deficiency, decreased pyridoxine or the vitamin B6. Kaya, expect mo kapag may isoniazid sa part ng treatment regimen mo, so B12 or the B complex supplement is usually given. Hyperuricemia, increased uric acid in the blood, is a common effect of pyrazinamide, double done. Ototoxicity, toxic to the ears. That is the streptomycin. What is the common symptom you watch out for as a sign of streptomycin? Sign of ototoxicity, sorry. Tinnitus, very good. If there's ringing in the ear or tinnitus, well, you're taking streptomycin, so that could be a sign of ototoxicity. Among these medication, which is used as a prophylactic drug for TB? Very good. It is isoniazid. Double done. So tatandaan nyo pag isoniazid, puro letter P. Causes peripheral neuritis due to pyridoxine deficiency, and it is the prophylactic drug for TB. So like for example, ako nag-positive ako sa TB. So yung mga kasama ko sa bahay, even before I am diagnosed, were already exposed to me bago pa ako ma-diagnose. So kung itetest din sila, kung mag-negative man sila sa sputum, still since they are exposed to me, they will be given prophylactic drugs. So mag-isoniazid sila. Okay, so prophylaxis, so as a prevention, especially if you are highly exposed. So what are important teaching kapag nagti-TB medication yung mga patients natin? Highly emphasized would be strict compliance. So they have to finish it. So hindi dapat na kapag feeling mo completely well ka na, feeling mo for example after a week, wala ka ng symptom, you feel well already. So di mo isa-stop mo na yung gamot. Okay, so that will defeat the purpose of taking the medication. So you have to clearly emphasize to them, you have to adhere to this treatment regimen. So this could be from 6 to 12 months. So 6 months, the usual. So pwedeng 9 months, pwedeng 12 months. Okay, so especially kapag mga immunosuppressed, usually mas matagal, up to 12 months. And after 2 to 3 weeks of taking medication, that's the only time you are considered non-contagious. Hindi ka na nakakahawa. Okay, so after 2 to 3 weeks. So no need for respiratory isolation naman ng sobrang tagal kasi after 2 to 3 weeks, di ka na contagious. Okay? And also, those who are exposed to you, expect, as mentioned a while ago, will be receiving prophylactic drugs. So kagaya ko, for example, kung nag-positive ako sa TB, so yung household, yung family members ko, so they will be receiving prophylactic drug for TB. Yung mga family members ko, kung mag-negative man sila, tas ako lang yung positive, titake sila ng isoniazid. And at home, no need for respiratory isolation kasi sa simula pa lang exposed naman na sila, no? So sa bahay, household, usually hindi na kailangan mag-respiratory isolation. Okay? So, and also we have sputum culture. So, yung sputum culture natin, tinitake to to identify kung mag-active TB ka. So, ito yung confirmatory test natin. Even mag-start ka ng maggamot, okay? So, even mag-start ka ng maggamot is i-check pa rin yung sputum. So, kahit naggagamot ka na, every 2 to 4 weeks, chine-check pa rin yung sputum mo. Kasi syempre, of course, for monitoring. Because if you want to go back to work, kailangan magkaroon ka ng negative sputum culture, 'di ba? So, i-monitor pa rin ang sputum. It is still necessary to monitor sputum even if you started medication already. So, hindi lang siya pang diagnostic test. So, continuous monitoring pa rin every 2 to 4 weeks while taking the medication. So, thorough hand washing, very important to emphasize. And, of course, proper etiquette with coughing. Cover the mouth and nose when coughing and sneezing. And make sure to properly contain yung mga used tissue mo since ito ay infectious waste, plastic bag dapat. So, make sure to seal it and put it in a plastic bag. Okay, para hindi mag-leak out. And you are only allowed to go back to work kapag mayroon ka ng 3 negative sputum culture. So usually it takes about mga 3 months para mag-negative sputum culture, maging negative sputum culture ka na. So more roughly 3 months or some could even be longer. Pero yung pinaka-usual is after 3 months. So that's the time you can go back to work. Pwede ka na, pero tutuloy mo pa rin yung gamot mo. Kung 6 months yung prescribe sa'yo, finish it. Okay, so for 12 months, so still finish it. So very important, adhere to treatment regimen. Finish it as prescribed. Isa ba sa cause ng neutropenic patient ang rifampicin at isoniazid? So kung bakit nagiging neutropenic, most likely yung TB? Yun ba yung question mo, Ruby? Kung bakit sila nagiging neutropenic? Kasi ano ko, pinastop na nag ano ko, pinastop na nag-severe neutropenic siya. 4 years old siya. Pinastop yung medication. So, depende kasi usually, yung mga medications naman, ito, yung mga nabanggit natin, yun yung mga common side effect, but there could be different effects then with patients eh. So, depende din yung response ng body natin. So especially for pediatrics, di ba? So, mas madalas, mas iba yung effect ng mga different medications with them. So, it could possibly, pero not at all times naman, na nagkukause siya ng neutropenia. Okay? And generally, yung ano din mismo, yung TB din mismo, 'di ba? So could impair your immune system, yun din mismo could directly cause the neutropenia. So possible, but not always naman. Okay? So yan. Practice question tayo. The nurse is preparing home care instructions for a client treated with tuberculosis. So which instruction should be included? So should be included instruction, so correct instruction for client treated for TB. Letter A, activities should be resumed gradually. Positive, negative. Resumption of activities gradually. Good yan. Positive, negative. Positive naman, no? Walang problema, 'di ba? Very good. So to prevent overexertion din. So letter B, Avoid contact with other individuals except family members for 6 months. Kailangan bang 6 months kang mag-isolate? Not necessary. Kasi sabi nga natin, after 2 to 3 weeks of taking medication, you are no longer contagious. No, letter C. A sputum culture is needed every 2 to 4 weeks once medication therapy is initiated. Chinecheck pa rin yung sputum kahit nagagamot ka na? Yes, every 2 to 4 weeks for monitoring. So that would be a basis din kung effective yung gamot, no? At para makabalik ka sa work, dapat magkaroon ka ng negative sputum culture. Respiratory isolation is not necessary na sa bahay, sa family members. Kasi exposed na sila anyway, even before you were tested positive. Yes. So at home, respiratory isolation would be unnecessary. But of course, pag hospital-based tayo, airborne precaution necessary. So at home kasi, bago ka pa na bago ka pa na-diagnose, exposed na sila. And they are taking prophylactic medication din, even if they are testing negative. Letter E, cover the mouth and nose when coughing and put used tissue into paper bag. Proper. So proper etiquette with coughing and tama naman, so proper containment of the used tissue. When one sputum culture is negative, client is no longer considered infectious and usually can return to former employment. Wrong. Oo, very good. So usually, you need at least, very good, 3 negative sputum culture. So usually after 3 months ka, nagkakaroon ng 3 negative sputum culture. So 3 negative sputum culture dapat, hindi isa lang. Double done. So here, can be included A, C, D, and E are all positive naman. Okay, very good. So that is tuberculosis. Commonly asked sa TB, yung precaution. Okay, so kagaya ng binigay ko sa inyong question kanina. So commonly asked, TB, the precaution, infection control. So part of infection control questions. So next, another hot topic in the examination, OSA. So recently lumabas to sa examination, obstructive sleep apnea. So with OSA, cessation of breathing or apnea episode when you are sleeping kasi nagkakaroon ng airway obstruction. Okay, who are at risk to have obstructive sleep apnea? Obesity, male clients, postmenopausal, advanced ages. So obesity being the most common risk factor for OSA. So with OSA, due to repetitive apneic episode, so nagkakaroon ng hypoxia, decrease O2, increase CO2. Okay? And that triggers SNS response, kaya possible complication as well is hypertension. So pwedeng magkaroon din ng elevated blood pressure with a client with OSA due to SNS response. Okay, so due to the repetitive apneic episode. So that is for obstructive sleep apnea. So whenever you sleep, nagiging obstructed yung airway, kaya nagkakaroon ng apnea episode. So ganito yung itsura. So normally, pag natutulog tayo, in a normal person without OSA, pag natutulog tayo, dapat open pa rin yung airway natin. 'Di ba? Kagaya dito. So freely flowing the in and out of air. Pero sa may mga sleep apnea, so nagkakaroon ng blocked airway. Kaya nagkakaroon ng apnea episode, cessation of breathing. Okay? So kaya ang goal natin with OSA is to manage the blocked airway. So kaya yung management would be more leaning towards managing the blocked airway, prevention of the blocked airway. So yun nangyayari with sleep apnea. Okay? So clear tayo dito. So most common sa mga obese client, so prone din sila for hypertension due to SNS response as a result of the repetitive apneic episode. So what are the common symptoms noted for a client with OSA? So most common symptom 3, letter S. So letter S, snoring loudly with 10 seconds or longer apnea episode. So ito yung mga nakakatakot pag natutulog, no? So they snore very loudly and then parang biglang tumitigil sa paghinga. So usually mga 10 seconds or more. So yun yung common symptom. There would be increased sleepiness at daytime kasi they feel not well rested at night. Diba? Kasi nga hindi quality yung sleep nila at night. And usually, sino yung nagre-report ng mga symptoms? Yung significant other. Oh, nakakainis na katabi. Exactly, KD. Usually, yun yung nagko-complain talaga. So, the significant other will be the one reporting the apnea episode. Okay, nung tulog ka kagabi, 'di ba? So bigla na lang siyang yung sobrang loud ng snore and then parang parang napuputol yung paghinga, 'di ba? Parang nakaka-anxious silang katabi. So yun yung nangyayari in a client with OSA kasi nga nagkakaroon ng obstruction ng airway. So ito yung mga ayaw mong katabi matulog lalo na pag gusto mong mahimbing ang tulog mo. Okay. So what is a common diagnostic test? Sleep study. Hot topic in the examination. Mark this down in your handouts. Okay. So put a star in this one in your handouts. Hot topic. So yung mga recent passers natin, especially this month, lumabas sa kanila, select all that apply. What are measured or what is usually done in a client on sleep study? Ano ba yung mga minomonitor? So sleep study, familiar kayo sa sleep study? Si sleep study, it's an overnight study. So, pupunta ka sa sleep laboratory. So, sleep laboratory or the sleep disorder center, social, no? May sariling, ano yan, may sarili silang center or area. So, yung tinatawag natin na sleep lab or the sleep disorder center. So, pupunta ka doon, mag-overnight ka doon para ka lang mag-hotel. Matutulog ka doon. Oh, matutulog lang, yun lang, as simple as that. Yun lang ang task mo, matulog. Okay? So, mag-overnight ka doon and while you are sleeping, so there will be a lot of monitors that will be hooked to you. Pero mga external monitors lang naman yon. So, ano yung mga monitor na i-expect natin kapag naka-sleep study ka? So, hot topic in the examination. Ito yung lumabas recently in the exam. Okay? So, if wag yung client mo naka-sleep study, nakakabit sila sa polysomnogram. So, pag sinabi natin polysomnogram from the name itself, poly, multiple test. Such as, yung mga test na done is EEG, electroencephalogram. So, brain activity mo habang tulog ka, minomonitor. EMG, muscle activity. ECG, heart activity. EOG, electrooculogram. So, rapid eye movement habang natutulog kami na monitor as well. Okay, so what else? Yung oral and nasal, airflow, temperature, and pressure. Okay, so merong sensor sa nose mo to check for oral and nasal airflow temperature and pressure. So additionally, si patient merong parang belt in the chest and the abdomen to check for chest and abdomen movement. Okay, so checking for chest and abdomen movement habang sleeping ka. And also expect that O2 is monitored through your O2 saturation pulse oximeter and yung tinatawag nating transcutaneous CO2. So transcutaneous CO2, external device lang din to check si CO2 level. So both oxygen and CO2 level are checked. Lahat to external device lang, nothing invasive. Okay, as simple as matutulog ka ng parang normal. So, pwede mong dalhin yung sleepwear mo, yung normal sleepwear mo. On the sleep laboratory, matutulog ka. And then, monitor itong lahat ng ito. Okay, so ECG, EMG, ECG, EOG, so oral and nasal airflow, chest movement, O2 sat, transcutaneous CO2. So lahat lang ay external. Parang nagla-lie detector, no? Ang daming nakakabit. Okay? So yon ang ginagawa. So matutulog ka lang. Okay? So hindi yan binibigyan ng sedative, normal na tulog mo lang. Lumabas yan recently in the examination. SATA of what to check. Okay? So what is our management for OSA? So management natin, since most common risk factor is obesity, weight loss program, of course. So weight loss is important. Sabi ni KD, makakatulog ka ba sa dami ng nakakabit sa'yo? Mako-conscious ka, no? But yes, you have to sleep. Okay? So hihintayin ka nila talagang makatulog para ma-check nilang lahat yan. Okay? So additionally, avoidance of alcohol. So with avoidance of alcohol, bakit importante to? Kasi alcohol causes the relaxation of the throat muscle, which causes the obstruction ng airway. Kaya avoid alcohol din. And also, common na parang conservative method muna. So, tatry muna yung parang mouthpiece, yung tinatawag na mandibular advancement device. So, mouthpiece siya na nilalagay sa mouth to prevent the blockage of airway. Kasi parang yan, to, kagaya nitong nasa picture. So, yung lower jaw, napupush siya forward para na-prevent yung closure ng airway. Kasi as mentioned a while ago, di ba, without the mouthpiece, yung airway natin obstructed. So with the mouthpiece, napupush yung lower jaw forward, so nape-prevent yung obstruction ng airway. So yan common na ginagamit. So conservative method, the mandibular advancement device or MAD. And most common, and lumabas din sa examination, CPAP. Okay, so a client with OSA, naka-CPAP or naka-BiPAP. So yung pinag-usapan natin kanina. And a client with OSA, yung CPAP or your BiPAP, susuotin mo lang ba yan kapag hindi ka makatulog or dapat continuously habang tulog ka na naka-CPAP ka? Susuotin lang ba siya 'pag di ka makatulog or dapat continuously through your sleep? Continuous, very good. Buong tulog mo nakasipap ka. Job well done. Okay, so hot topic yan sa examination. So take note of that. Pabalik sa previous slide, no problem. Okay, so sila yung gumagamit ng CPAP, BiPAP. Worst case scenario, there are also surgeries that are done. But usually, ano siya parang last resort and kasi hindi pa din gano'n parang hindi naman gano'n din mataas yung effectiveness in terms of managing the OSA with a surgical approach. So more of the CPAP yung nakikita natin sa may mga OSA. Okay, malinaw tayo dito. So tandaan yung mabuti ha kung ano yung minomonitor sa sleep study. Lumabas yan as select all that apply recently in the examination. Very recent. Clear tayo? Balik ko lang sa previous slide as requested. This one, JR. Thank you as well. Okay, so clear tayo with obstructive sleep apnea. So take note of the sleep study. And they are the ones commonly prescribed with the CPAP or the BiPAP to keep their airway open when they are sleeping. So it should be used continuously while they're sleeping. So next, we have the disorders of the pleura. Pleura, pag sinabi nating pleura, that is the outermost layer of the lung, 'di ba? Yung pinaka-outer. So with the pleura, kagaya sa heart, kung naalala nyo nung nag-discuss tayo for cardiovascular system, the pericardium, yun naman yung outermost layer of the heart, 'di ba? Sa pericardium, may small amount of fluid, the pericardial fluid, to prevent friction and to allow free cardiac motion. Sa pleura, ganun din. In the pleura, the outermost layer of the lung, normally may small amount of fluid, about 10 to 20 ml din. So very minimal. Okay, so there's space also there. So yung pleural space contains about 10 to 20 ml of fluid just to prevent friction as well. So same. Okay, but if there would be excess build up in that space, so that could lead to your pneumothorax, pleural effusion, hemothorax. So ang difference lang, ano yung nag-build up. If it's built up of excess air that causes the pressure, so that is pneumothorax. So pag air yung nag-build up in the pleural space, so that is pneumothorax. Kapag yung excess build up naman is fluid, you call that as pleural effusion. And if the build up in the space is blood, that is hemothorax. So yung difference lang nilang tatlo, kung ano mismo yung nag-build up into the space. Pneumothorax, it's air. Pleural effusion, it's fluid. Hemothorax, it's blood. And all of that causes pressure in the pleural space. So if it causes pressure into your pleural space, so mapupush na yung lungs. And what could happen? The lungs will collapse. So yung affected lung natin could collapse. Kaya common complication in a client with pneumothorax, there's lung collapse of the affected side. Okay? So this could be due to infection, malignancy, so cancer, diba? So lalo na yung pleural effusion, common for cancer complication. Or trauma. So trauma, like for example, motor vehicular accident, so pwede magkaroon ng pneumothorax, diba? Or for example, sabi natin kanina, natanggal yung ET tube, tapos hindi mo na cover yung insertion site, so may open chest wall ka, so papasok yung air, magkakaroon ng pneumothorax. Okay? So those are the different build-up. So air for pneumo, pleural effusion fluid, hemothorax is blood. So when we say pneumothorax, there are different types. Could be spontaneous pneumothorax. So nagkaroon ng buildup of air due to sudden rupture of pulmonary bleb. So spontaneous rupture of pulmonary bleb. Open pneumothorax naman, so common to kapag may open chest wall. Okay, so like for example, may mortal enemy ka, inabangan ka sa kanto, pinagsasaksak ka, so open chest wall. No? So pumasok yung air into your pleura, so that is an open injury. So that causes pneumothorax. Tension pneumothorax, blunt injury naman. So due to blunt injury, for example, blunt injury to your chest, so meaning walang opening. So opposite ni open pneumothorax, so closed. So for example, motor vehicular accident, tumama yung chest mo sa steering wheel. So nagkaroon ng blunt injury into the chest. So that causes tension pneumothorax. Or this could also be a complication with prolonged use of PEEP. PEEP, positive end expiratory pressure. So that is a setting in the MEC vent. So usually very careful yung mga doctors with putting PEEP kasi too much nga can cause tension pneumothorax. So usually the PEEP is a setting in a MEC vent to keep alveoli inflated. So those are the different types. So what are the common symptoms for a client? So since respiratory condition pa rin, pulmonary symptoms pa rin, dyspnea, tachycardia, tachypnea. And sabi natin, nagkakaroon ng collapse of the affected lung, no? So there is problem with breathing. There could be cyanosis related to hypoxia. There will be decreased absent breath sound saan? Dun sa affected, unaffected side. Where do you expect decrease or absent breath sound? Affected, unaffected. Affected side. Very good. Kasi nga nag-collapse yung affected lung. So there's decrease or absent breath sound sa collapsed lung. So na-appreciate mo lang yung lung sound sa unaffected side. Very good. So there would be decreased lung sound sa affected kasi nag-collapse nga yung affected side, yung affected lung. There will be unilateral chest expansion. Since nag-collapse nga yung affected lung, so ang nag-expand lang yung unaffected side. And also, there will be sucking sound or open, usually parang sucking sound heard during dun sa open chest wall. So take note, this is only noted kapag open pneumothorax. Another name for open pneumothorax is traumatic pneumothorax. So may open chest wall. So ito, yung sucking sound, ina-expect mo lang yan kapag open pneumothorax. So walang sucking sound kapag spontaneous or tension pneumothorax kasi wala namang opening doon. More importantly, priority to watch out for pneumothorax is tracheal deviation. So ideally, sabi natin kanina, yung trachea dapat nasa midline lang, nasa gitna. Pag nag-shift yan or nag-deviate into one side, that is a respiratory emergency. So in a client with pneumothorax, where do you expect trachea to deviate? To the affected or unaffected? Very good, Arlene. So watch out for tracheal deviation towards the unaffected side. So look at the picture. So for example, okay. So for example, this is the uh, left lung and this is the right lung. Okay. So for example, left pneumothorax tayo. So left pneumothorax, nag-collapse yung left lung mo. So there's increased pressure in the left lung. Napupush yung trachea papunta dun sa, since nandito yung increased pressure, napupush yung trachea papunta sa unaffected side. Very good. So there's decreased breath sound sa affected side kasi nag-collapse yung affected lung, but there is risk for tracheal deviation towards the unaffected kasi there's increased pressure on the affected side, doubled on. So that is for pneumothorax. So take note of the possible complication to watch out for. So what management do we expect for this one? So I summarize with the mnemonic trap. Okay? So since may trap na pressure, so trap. Letter T, anong gagawin natin? May build up of fluid, build up of air. Okay, fluid pag pleural effusion, air kapag pneumothorax, blood pag pneumothorax. So gusto natin matanggal yung build up kasi yun yung nagkakos ng pressure. So paano matatanggal yon? Aspiration, no? So centesis is aspiration in the lungs. Okay, so in the pleural cavity, thoracentesis. So thoracentesis will be done. And also to promote drainage pa rin and promote lung re-expansion of the affected site, CTT. So patient could be hooked to chest tube. So to promote drainage and promote re-expansion of the affected site as well. Regulate oxygen as ordered as needed because there could be problem with breathing, dyspnea. So give oxygen as ordered as needed. And for open chest wall, priority natin para hindi na pumasok yung air on the open chest wall, cover, diba? The open chest wall. So cover with sterile gauze. So non-porous dressing. And to maximize breathing effort pa rin, Fowler's position, elevate head of bed. So generally, mapapansin nyo, pare-pareho yung position, no? Pag nahihirapan huminga, you want to maximize breathing effort, elevate head of bed. So Fowler's position. So that is for pneumothorax. So buildup of pressure in the pleural cavity, so which can cause in the trachea to deviate into your unaffected side. Are we clear for pneumothorax? Clear tayo? Let's practice. Sige. So if this is clear, let's try to answer this question. The trauma nurse is assessing a client with sustained blunt injury to the chest wall. So which finding would indicate the presence of pneumothorax? So symptom related to pneumothorax, may blunt injury in the chest wall yung client natin. Letter A, low respiratory rate, diminished breath sound, the presence of barrel chest, or the sucking sound at the site of injury. What is your answer? A, B, C, or D? What do you expect for a client with pneumothorax? So some answered B, some answered D. Sucking sound at the site is noted for pneumothorax. But, okay ba, noted ba yun pag blunt injury? Pag blunt, closed yun. Very good. So this is noted for open pneumothorax. So wala namang open chest wall kasi blunt injury lang daw eh. So this is not expected. Oo. So tama yan kapag open pneumothorax or the traumatic pneumothorax. Okay? Letter C, presence of barrel chest. When do you expect barrel chest? Barrel chest is for COPD. Very good. So not related. So not A and B na lang. Low respiratory rate or high respiratory rate? Tachycardia, takip niya, 'di ba? So this is not the one that is expected. Very good. So the best answer, diminished breath sound, 'di ba? Absent and diminished breath sound. Bakit? Nag-collapse yung lung. So where do you expect diminished breath sound? On the affected or unaffected? Affected side. Okay, very good. Kasi nga collapsed lang yung affected side. Where do you expect tracheal deviation? Where to watch out for tracheal deviation? Towards the unaffected. Kasi napupush yung trachea, that mataas ang pressure sa affected side, napupush on the opposite side, unaffected side. Job well done. Okay, very good. So another disorder of the pleura, we have the pleurisy or the pleuritis. So from the name itself, itis, inflammation of the pleura. So namamaga. So this could be due to infection, trauma, or cancer as well. So common symptom with pleurisy, since there's inflammation of the pleura, so anong mangyayari? Nagra-rub together yung pleura. Diba? The outer and the inner pleura. So nagra-rub together, there will be friction rub. And since nagra-rub together, it will be painful. So there will be knife-like pleuritic pain. So worsen with deep breathing, coughing, sneezing. So if there's exertion, mas noted yung pain. So usually occurs only on one side. So localized and can radiate even to the shoulder and the abdomen. So pag with pleuritis or pleurisy, so nagra-rub together yung pleura, kaya may pain and kaya din may friction rub. So parang dun sa pericarditis, no? With pericarditis, nagra-rub together yung pericardium, the outer and the inner pericardium, kaya may pain din and may friction rub. Pero yon pericardial friction rub. So ito pleural friction rub. So in the pleura. So what management do we expect for this client? So management natin, treat the underlying cause. So kung cancer yan, so treat the cancer. So kung infection, treat the infection. And of course, since pain is the most common symptom, pain medication, okay, analgesic NSAIDs. And to provide comfort to your client as well, how do you best position your client? So you turn your client towards the affected or unaffected side. So with pleurisy or pleuritis, you turn on the affected or unaffected. Very good, Arlene. Affected to promote splinting of the affected site, diba? So affected dapat. Okay, so double done. So para siyang splinting. Kaya kapag may exertion as well, you teach your client to promote splinting. So put the hands or pillow to splint the rib cage. Okay, especially when coughing, when sneezing, or during exertion. So that's why you turn then on the affected side to promote parang splinting as well. So turn on the affected side. So that is for pleurisy or pleuritis. So last topic for today, we have the different respiratory complication. So most common, we have the flail chest. Pag sinabi natin flail chest, so this could be due to a blunt chest trauma. Okay, so especially common din kapag nagkaroon ng fractured rib, like for motor vehicular accident. So anong nangyayari with flail chest? So the most common symptom in flail chest, very good JR, the paradoxical breathing. What do we mean by paradoxical breathing? In a normal person, for example tayo, in a normal person, pag nag-inhale tayo, what happens? We are filling our lungs with air. So our chest expands, 'di ba? So nag-expand yung chest natin pag nag-inhale tayo. And then when we exhale, yung chest natin or yung lungs natin goes back to in its original state. Okay? Ngayon, with paradoxical breathing in a client with flail chest, what happens? So paradoxical, unusual, abnormal. Anong nangyayari? So with flail chest, pag nag-inhale sila, nagsasak inwards yung chest. Pag nag-exhale sila, okay, during expiration, palabas naman, move outwards yung chest wall. So, ganon. Pag inspiration, sucking inwards yung chest. Pag expiration, palabas, baliktad. No? So, kaya siya tinawag na paradoxical breathing. So, that is a usual, unique symptom for flail chest. So, there's severe pain in the chest as well, dyspnea, cyanosis, so related to hypoxia. So patient could have shock as well. So kaya hypotachy-tachy will be noted. So there could be diminished breath sounds. And more importantly, watch out for tracheal deviation towards where? Affected, unaffected. Okay, since may, so sabi natin, di ba, may could be related to rib fracture. So the trachea could deviate towards the affected. Okay, so towards the affected side. Okay, very good. So towards the affected side. So kung saan may rib fracture. Okay, so pwedeng doon mag-deviate. So tatandaan, kapag, so summarize natin, kapag post-pneumonectomy in client with flail chest, watch out for tracheal deviation towards the affected side. Kapag naman pneumothorax, watch out for tracheal deviation towards the unaffected side. Okay, so clear tayo dyan. So most common symptom, paradoxical breathing. So nagsasak inwards yung chest during inhalation or inspiration. In opposite naman, suck outward. So moves outward pag exhalation. Unlike the normal, kapag nag-inhale tayo as a normal person, so dapat nag-expand yung lungs natin during inhalation and then goes back to original state during exhalation. Clear tayo dito? No problem, Cecilia. Sige, balik ka sa previous slide. Okay, so flail chest, so could be due to blunt chest trauma, but more commonly than due to fractured rib, diba? So pwede ring motor vehicular accident ang common cause. No problem. Okay, sige. So what is our management? Management natin, so summarize with the mnemonic flail. So to maximize breathing effort of your patient, Fowler's position pa rin, elevate head of bed. Limit activity, so bed rest to decrease O2 consumption. Then, diba? So to promote rest, decrease O2 consumption, administer oxygen as ordered and as needed. And usually, since emergency nga ito, so yung oxygen nila more of mechanical ventilation. So to keep their alveoli inflated, so they are on mechanical ventilator with PEEP, positive and expiratory pressure. And of course, pain management then would be necessary kasi may chest pain din. So since may rib fracture involved din. Okay, so that is for flail chest. So usually these patients are mechanically ventilated to help them with their breathing and to also, very important, so decrease O2 consumption by promoting bed rest as well. So to promote healing. So next we have the pulmonary embolism. With pulmonary embolism, this is obstruction of the pulmonary artery by a thrombus. Kung naalala nyo yung DVT, na-discuss natin sa cardiovascular system. So with DVT, may mga clots ka sa deep vein. So for example, nasa legs. Na-massage mo yon, nag-travel, okay, yung nagaling sa legs mo, nag-travel into your circulatory system, nakarating sa pulmonary artery, bumara sa pulmonary artery. So that leads to pulmonary embolism. Okay, so that's why anyone at risk for clot formation, they could be at risk for pulmonary embolism. So trauma, surgery, pregnancy, hypercoagulable state, prolonged immobility. So anong common denominator nilang lahat? So they are all at risk for clot or thrombus formation. So yung embolus are clots that are dislodged in yung nag-travel into your circulatory system. Kapag na-stuck yan sa pulmonary artery, so that leads to your pulmonary embolism. So the embolus could be air embolism. So from your IV, no? So like for example, may air sa infusion mo. Fat embolism, common yan kapag mga fracture. So especially long bone fracture. So fracture of the legs. So nag-escape yung fat embolus into the circulatory system, so that leads to fat embolism. Amniotic fluid embolism, so related as a complication of pregnancy. So common yan sa mga pregnant, post-delivery. Okay. Septic. So septic from the name itself, septic, so related to infection. So those are the different types of embolus. So with pulmonary embolism, still dyspnea would be noted. So generally, lahat naman may problem with breathing. So sudden pleuritic chest pain, most common symptom, there will be sudden pleuritic chest pain. Okay? And there's tachypnea, tachycardia. Patient could have shock-like symptoms. So tachycardia, tachypnea, even hypotension, restlessness, feeling of impending doom, and cyanosis. So commonly noted. So cyanosis in the chest pain. So most common symptom in a client with embolism, sudden. So sudden pleuritic chest pain. So what is your management? So management, elevate head of bed pa rin to maximize breathing effort. Okay, so elevate head of bed. Pag pulmonary embolism. Pero pag specific na air embolism, ano yung proper position natin pag air embolism? Okay, pag air embolism, anong position? Durants, very good. So Durants are the left Trendelenburg's position. Very good. So left Trendelenburg's position. Bakit left Trendelenburg's? What is the purpose of putting your client on left Trendelenburg's position pag air embolism? That is to trap the air. Oo, very good, Teresa. To trap the air at the right atrium. So para umakyat yung air into the right atrium, hindi na yan mag-travel. Kasi pag nag-travel pa yung air, papunta sa pulmonary artery. So that's the time it becomes pulmonary embolism. So kapag pulmonary embolism, to maximize breathing effort, elevate head of bed pa rin. Okay, so patient would be usually hooked to mechanical ventilator. Okay, so also oxygen. Medications natin, thrombolytics, anticoagulants, kasi thrombus or clot formation nga ang concern natin. So monitoring of blood gases, of course, to check for oxygenation ng client natin. In worst case scenario, surgical approach, embolectomy. Pero rarely done to si embolectomy. So kapag talagang hindi pwede, so more initially, more of anticoagulation, thrombolytics, and oxygen therapy ang management natin. So last resort lang yung surgical. So that is for pulmonary embolism. So pulmonary embolism, yung mga embolus na dislodge or na stuck sa pulmonary artery. So most common symptom, sudden chest pain, restlessness, cyanosis. So especially yung mga naka-central catheter. So could be at risk for pulmonary embolism yan. Okay? So anyone at risk for clot formation or thrombus formation could be at risk for pulmonary embolism as well. Kasi doon manggagaling. So embolus are clots that are dislodged into the circulatory system. So lastly, we have ARDS, acute respiratory distress syndrome. So in ARDS, this could be a complication of different respiratory condition. So like for example, yung pneumonia. Yung pneumonia, pwedeng mag-progress to ARDS, diba? So ganun siya. So yung other respiratory condition could progress into acute respiratory distress syndrome. So due to may present acute lung injury, so that causes inflammatory response, so thus leading to alveolar collapse, increased airway resistance, decreased lung compliance, and also pulmonary vasoconstriction, thus all leading to hypoxemia. Kaya ang most common symptom of acute respiratory distress syndrome is that yung O2 sat nila persistently drops despite giving of oxygen. So nagbibigay ng oxygen, hindi nagre-respond. So bumabagsak pa rin yung O2 sat, so that is a sign of hypoxemia. So for example, may pneumonia, severe pneumonia, pwedeng mag-progress to ARDS. So hindi nagre-respond to oxygenation, hypoxemia could occur. So the persistence dropping of the O2 sat despite giving of oxygen. So that is the most common symptom in a client with ARDS. Okay, so acute respiratory distress syndrome. So this could be a complication of other respiratory condition. So pwede siyang maging complication ng mga ibang respiratory condition. So yung mga nabanggit nating respiratory diseases, So pwedeng mag-complicate into ARDS. So what are the symptoms to watch out for? So summarize with ARDS. As mentioned, the most common symptom, arterial hypoxemia. Bumabagsak na O2 sat despite giving oxygen. Okay? So that is the most common noted or warning sign of ARDS. Restlessness, so respiratory acidosis could happen. So there's diminished or absent breath sounds in severe dyspnea. So in a client with ARDS, commonly asked in the examination would be, how do you position if ARDS occur? What would be the best position for a client having ARDS? Very good, JR. Ito yung mga nakikita nyo sa ICU na naka-prone position. So, nakabaliktad. So, hindi nila trip lang naka-prone lang. So, pinoprone yan for a reason. Okay? So, ARDS, that is the one that is placed on prone position. What is the purpose of proning the client? Kasi with ARDS, the problem is there's unequal blood and airflow. So to equally distribute blood and airflow, to evenly distribute it, to improve gas exchange as well, so proning position would be beneficial. So sila yung mga nakikita nyo na sa ICU na naka-prone position. So most likely complicated into ARDS. Okay, so tatandaan, prone position. So mapapansin nyo, sa lahat ng respiratory condition na nabanggit natin, basta may problem with breathing, elevate head of bed. Okay, but for ARDS, ito yung specifically placed on prone position to equally redistribute blood and airflow. So to improve gas exchange. Kasi most part of the respiratory system din naman na, so usually yung parang most part din ng respiratory, especially the lungs, nasa posterior part. Kaya mas better din yung prone position. Kaya that improves the gas exchange. And also, of course, expect patient would be hooked to mechanical ventilator to help with the breathing of your client. So still would PEEP, the positive and expiratory pressure to keep the alveoli inflated. And most importantly, treat the cause as well. So as mentioned, ARDS, hindi siya directly ARDS agad. So most of the time, merong underlying cause, other respiratory condition. So treat the underlying cause. So determine and treat the underlying cause. So kung pneumonia yan, so treat as pneumonia as well. Because most commonly, ARDS is a complication of other respiratory conditions. So like for example, yung pneumonia nga natin, nag-complicate to ARDS. So ARDS can be a cause of death of a client with severe pneumonia. COVID, very good. Exactly, Angelica. So yung mga may COVID, hindi naman sila namamatay just with COVID itself. Usually, nagko-complicate siya sa ARDS with severe COVID. Very good. So yun yung mga naging common cause of death ng mga client na may COVID. Kaya nga din sa COVID, 'di ba, ine-encourage din na prone position. 'Di ba naalala nyo kapag, for example, kung ayaw yung sa home treatment ka lang, ine-encourage ka din na if you sleep, try to sleep then on prone position. That would be better. So that would maximize the distribution of blood and airflow as well. So that would improve gas exchange as well. Kaya nung dati nung uso yung COVID, 'di ba? Ine-encourage na if you are with symptoms with COVID, kung kahit mild symptoms ka lang na with COVID, so it's better that you sleep on prone position. Okay, very good, Angelica. So lastly, of course, they will be sedated to decrease workload, diba? So to decrease O2 consumption. So they could be sedated, especially while on prone position. So nakasedate din sila. Okay, so that is acute respiratory distress syndrome. Clear tayo dito? Any questions, any clarifications from everything that we have discussed? Last na to. So this is the last topic we have for today. May questions ba kayo or clarification? None naman. Sige, kung wala, let's have a quick recap before you take your post-test. So with normal breath sounds, again, ano yung mga normal breath sounds natin? Tatlong normal breath sound. What is the breath sound heard over the trachea? So over the trachea, it is over the trachea, bronchial. And over the bronchi, so sa bronchi, bababa, it is the combination, no? So the bronchovesicular. And lastly, all throughout the lung field, letter V, the vesicular. So B, BV, and then V all throughout the lungs. Double done. So kung may normal, meron din tayong abnormal. Pag sinabi natin crackles, crackles is commonly described as what? Musical snoring, grating, bubbling, crowing. It is the bubbling sound, crackling sound, popping sound, usually associated with pulmonary congestion, fluid in the lungs, secretions in the lungs, right? Very good. Wheezing is described as musical Very good. Whistling sound heard during inhalation, exhalation. Inhalation, exhalation. Exhalation. Related to upper or lower obstruction. Upper or lower airway obstruction. Lower, bronchoconstriction. Very good. Kaya common to pag asthma. Very good. Ronchi. Ronchi is commonly described as the snoring sound as the air passes through an airway filled with mucus, the turbulent sound. Friction rub. So friction grating, very good kasi nagra-rub together. So like in a client with pleurisy, diba? So there could be friction rub. Stridor. Stridor, that is the crowing sound. In stridor, this is heard during inhalation or exhalation. Inhalation. Sign of upper or lower obstruction. Upper airway obstruction, laryngospasm, no? Very good. Kaya common siya, epiglottitis. Okay, so laryngotracheobronchitis or LTB or the CRU. So upper airway obstruction. Very good. So next, in terms of your ABG, acidosis or alkalosis, hypoventilation, respiratory acid, alka. Hypo, that is acidosis, right? So retention of CO2. Anxiety. So with anxiety, alkalosis. So related to hyperventilation. COPD. Trapping of CO2 pa din. So acidosis because CO2 is acid. Early stage of asthma. So early stage of asthma, alka pa. Pero kapag totally constricted na yung airway mo, late stage of asthma, so that is acidosis na. Fear hysteria. So that is related to hyperventilation pa rin, alka. Increased intracranial pressure, very good since there's hypoventilation but dypnea, acid pa rin. Excessive mechanical ventilation, so that leads to alkalosis. Parang hyperventilation lang. Okay, great job. Metabolic acidosis, alkalosis naman. DKA. Acidosis, very good. Vomiting, vomiting. Pag nagva-vomit ka, di ba, you sound like ok. Okay, so alkalosis. So ganun din pag GI suction, you're losing gastric content. You're losing gastric acid. Diarrhea, diarrhea, acidosis. Very good. Sabi nga kanina ni JR, as, no? Para matandaan, as. Okay, so that is acidosis. Excessive sodium bicarbonate. So sodium bicarbonate is alkaline in nature. So you have that, alkalosis. Renal failure. So your body is unable to excrete the renal acid. So acidosis. Hyperkalemia. So that is related to acidosis. So as opposed to that, hypokalemia, alkalosis. Loop diuretic. So you are excreting renal acid, alka. Aspirin toxicity, lactic acid release. So that is acidosis. Double done. Okay. High pressure versus low pressure alarm. Wheezing, bronchospasm. High. Anything related to obstruction. In key secretions. Obstruction din yun, no? So high. No spontaneous breathing, apnea episode. So walang spontaneous breathing, nag-apnea, low pressure alarm. Endotracheal tube is displaced. Nandun pa rin yung tube pero not proper position. Obstruction yon, high. Pag natanggal na yung tube, saka maglo-low. Fights the ventilator, naglalaban, high pa din. Disconnection, disconnected tubing. So magli-leak out, that would be low. Kinks in the tubing. Kink causes obstruction in the flow, high pressure. Obstruction in the mech vent, so high pressure. Leak. So that is low. Very good. Natanggal na yung ET tube mo. That is low pressure alarm. Job well done. Okay. So COPD versus asthma. Irreversible. 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 Hindi na re-reverse. COPD. Progressive and irreversible. Barrel chest. Sino yung may barrel chest? COPD. Specifically, what COPD yung may barrel chest? Emphysema. Very good. Reversible. Reversible. Asthma. Oo. Kaya nga yung symptom ng asthma parang bronchitis pero reversible. Loss of elasticity. Loss of elastin. So related to COPD especially emphysema. Diba? Kaya may barrel chest appearance. Smoking is a common risk factor. So common for COPD. Very good. Trigger is allergens. Asthma. Peak flow monitoring is used for what? Peak flow monitor to check for severity of symptoms of asthma Okay, very good. And also effective that as treatment regimen. Low flow oxygen lang ang pwedeng ibigay. COPD. Okay, very good. So para to prevent the loss of hypoxic drive. Bronchoconstriction and inflammation. Asthma. Meron din sa COPD na bronchoconstriction and inflammation? Both. Okay. Very good. Mute ko lang ha. Okay? So very good both, 'di ba? So pareho, it's just that the bronchoconstriction and inflammation in COPD is progressive and irreversible. But in asthma, it is reversible. Okay, great job. So pareho. TB medications. So in terms of TB drugs, identify optic neuritis is common for what TB medication? Optic neuritis, ethambutol, letter E for eyes. Red-orange urine, watch out for kapag nagtitik ng rifampicin, double done. Peripheral neuritis is a common effect in a client taking isoniazid. Very good. Okay, so isoniazid due to the B6 deficiency or the pyridoxine. Hyperuricemia. Hyperuricemia for pyrazinamide. Ototoxicity is manifested by tinnitus is associated for streptomycin. And the prophylactic drug for TB, so for those with exposure, expect to receive isoniazid. Okay, great job. So that is for TB medication. So lastly, yung mga common symptoms. Paradoxical breathing is common noted for what respiratory condition? Paradoxical breathing. That is for flail chest. Very good. Rusty sputum can be associated with pneumonia, rust-colored sputum. Blood tinge sputum naman, kanino noted? Blood tinge. TB, blood tinge, blood streak, and hemoptysis, no? Watch out for tracheal deviation to unaffected side, unaffected. So yung mataas ang pressure in the affected side, pneumothorax. Very good. And wala na tayong choice. So pleurisy. So yung may friction kasi may inflammation. So pleural friction ba. Very good. Okay. So job well done, everyone. Sige. So thank you very much for your active participation all throughout our lecture. Sige. So do you have any questions or clarification before you take your post test? Kung wala, you can take your post test. So God bless you and see you in a while for rationalization. So be back after 20 minutes and then we'll rationalize the post test. 9:50. Be back ng 9:50 tas ration tayo. See you in a while. Thank you very much, everyone. Are you done? Ready for Rasho? I only see a few. Meron pa bang nag-answer? Ay, sige. So answer na natin yung ating post-test. First question, click to specify which acid-base imbalance are the following at risk for. Okay, so simply identify ano ang acid-base imbalance noted for the client. Diabetic ketoacidosis. What acid-base imbalance? DKA, we expect. Metabolic. Anong sagot natin? DKA, metabolic acidosis. No, met acid. Vomited 3 times, vomiting. So vomiting could lead to vomiting naman could lead to metabolic alkalosis. Okay, very good, met-alka. How about continuous NGT suction? NGT. Ganun din. Kagaya din, no? Met-alka din losing gastric content. So losing gastric acid. Asthma, late stage of asthma. Late stage of asthma, it could lead to respiratory acidosis. Client who is hyperventilating due to anxiety. Hyperventilating due to anxiety, that is respiratory alkalosis, hyperventilation. Client having loose watery stools, diarrhea. So diarrhea could lead to metabolic acidosis. Okay, very good. So that is for question number 1. Okay, great job. Next question number 2. So which blood gas result would you expect for an adolescent with DKA? So sabi nyo kanina, pag DKA, risk for what? What acid-base imbalance are we looking for? So clue mo na yung DKA, we're looking for met acid. So alin dito ang met acid? Acidosis, so test taking strategy, focus ka sa pH na mataas, mababa. Acidosis. We're looking for pH that is low. So tanggalin na agad natin yung C and D, no? So test taking strategy, dalawa na matatanggal natin. Both pH are low. Since metabolic, focus tayo sa bicarbonate. So bicarbonate should be equal to your pH. So bicarbonate should be low. So alin ba dito ang may low bicarbonate? So parehong may low pH, alin ang may low bicarbonate? A or B? So it is A kasi this is high. So gusto natin yung low bicarbonate. Kaya that's why the best answer should be letter A. Very good. That is metabolic acidosis. Job well done. Question number 3. The UAP tells the nurse that the patient is receiving O2 at 6 liters per minute via nasal cannula. So reports nasal passage discomfort. What intervention should the nurse suggest to improve comfort? Okay, so focus improvement of the comfort. Ang problem, nasal passage comfort. So that is to humidify. Very good. Definitely letter A. So focus on the problem. It is nasal passage discomfort. So not necessary naman to change into mask. Letter C will promote comfort in terms of position but not related to nasal passage comfort. So same goes with letter D. So more of positioning, no? So not related to the nasal passage. Job well done. So should be letter A. Number 4, you are caring for a 5-year-old boy hooked to nasal cannula 6 liters per minute pa rin. So which instruction should be included in the care plan? Select all that apply. So we're looking for correct teaching regarding O2. Letter A, instruct to visitors not to smoke cigarette in the patient's room. Correct? Yes, positive. Very good. How about letter B? Remove woolen blankets and friction toys. Positive. Yes, positive then. Very good. Letter C. Provide the client with humidifier. Positive din, no? To humidify the air to prevent dryness of mucosa. Letter D, instruct not to increase oxygen level if difficulty, instruct to increase pala, oxygen level if difficulty of breathing occurs. Pwede bang basta-bastang yung patient ang mag-a-adjust? No. As prescribed yun, no? So tayo nga hindi tayo basta mag-a-adjust, yung patient din hindi pwedeng basta mag-adjust. Okay, very good. So that requires doctor's order. Letter E, instruct client that he cannot eat while on nasal cannula. Bawal ba kumain habang naka-nasal cannula? Pwedeng-pwede, no? Very good. Not a problem. So A, B, and C are the only positive statement. Job well done. Next item, we have number 5. You receive a client newly inserted with endotracheal tube, newly inserted. So, hinahanap natin method that is best to check for proper placement. What is the answer? So, best way to check? X-ray. So, very good. So, all could be methods to check for placement, but the best is X-ray. Very good for visualization. Number 6, so care for a 50-year-old male client. The client is diagnosed with PTB. He is intubated and on MECVEN. The client is noted with coughing more frequently. Vital signs, normal naman. So ngayon, the nurse notes ventilator was signaling high pressure alarm due to blank and will blank. Yes, question, Justin. Justin, ano yung question mo? Since newly inserted, parang expected assessment po first sa bedside. You mean sa previous question? So dito, previous question, like after na po yung request for chest x-ray. Kasi ang tinatanong dito, best to check eh. Oo, so best to check. Okay? Best ang tinatanong, no? So meaning, the most ideal way to check. Oo. Okay. So di naman sinabi din na first way to check. So it's more of the best. Oo. So kaya be mindful yan mga terms na yan. So best talaga x-ray kasi nakikita visually kung nasaan yung tip ng catheter. So that's the best. Sige. So ngayon, going back to question number 6. Okay, so with number 6, high pressure alarm daw. So the high pressure alarm in the mech vent is due to blank and blank. Okay, so due to blank and blank. So due to blank and will blank. Ano ba yung mga nagkukos ng high pressure alarm? So self-extubation, apnea episode, leak, endotracheal tube. Test taking strategy, self-extubation, low pressure alarm. Apnea, low pressure din. Leak, low pressure din. So very good. Dito lang, secretions. And sabi dito, coughing frequently. So related to secretions, no? Okay. So ngayon, will, anong gagawin natin kung may secretions? Magsa-suction tayo. Nagmadali 'no, oo, medyo nagmadali lang. Okay, so endotracheal tube, initiate suctioning. So that is the correct answer. Okay, great job. Next, we have number 7. You are caring for a client hooked to MECVEN due to severe pneumonia. So click to specify which of the following scenario can cause low versus high. So identify lang kung low or high. Self-extubated, high or low. Natanggal ang ET tube. So nagli-leak out na, very good, low. Secretions build up. Secretions build up, so obstruction yon high. Patient ventilator mismatch. So nagkakaroon ng mismatch ng breathing ng patient and ventilator, high pressure. Very good. So parang fighting the ventilator din, no? Kapag anxious din yung client. So same. Leak is noted on the tubing, leakage. So that is low pressure alarm din. ET tube is displaced. So in pa rin, pero not proper position, high. Very good. So pag self-extubated, natanggal na ang tube low. Water buildup in the tubing. So pag may water buildup sa tubing, obstruction din yun. High pressure alarm. Very good. So that is for high versus low. Double done. Anything related to obstruction, high. Kapag nagli-leak out yung air, that is for low. Next, we have number 8. So after the respiratory therapist performs suctioning on a patient who is intubated. So after suctioning daw. So the UAP measures vital signs. What vital signs daw should be reported immediately? Priority to report. Very good. Letter D. Okay. So post-suctioning, elevated vital signs can be expected like the heart rate, RR, BP, medyo tataas, no? Pero hindi expected na tumaas ang temperature post-suctioning. Kasi kung mataas ang temperature, meaning sign of infection, no? Oh, very good. So letter D. So dito talaga, syempre nag-suction ka, may exertion. So stress, induced, tataas ang BP, tataas ang heart rate, tataas ang RR. Pero hindi tataas ang temperature pag nag-suction. So very good, meaning may problema. Ma'am, question po, kailan po pwede isagot yung blood pressure? So pwedeng isagot yung blood pressure Kung for example, wala yung option letter D, so pwede nating isagot yung BP kasi siya yung pinaka mataas, no? So, yung BP medyo mataas na. So, ito, elevated yung blood pressure, pero kung ikukumpara mo sa temperature, so mas abnormal yung temperature, mas immediately reportable kasi sign of a complication, which is infection. So, baka may pneumonia na yung patient natin. Na, okay. So, ngayon, mas expected yung A, B, and C. Kung wala yung letter D, kunyari A, B, and C lang, so pinaka-priority mo nang i-report yung letter C kasi siya yung pinaka-abnormal among all the vital signs. Okay. So yun, kaya very important pag priority ang tinatanong, you really have to compare all options. So identify mo alin ba yung mas expected, alin yung mas reportable, alin yung mas emergency. Okay? Number 9. So, sino daw ang risk for failure to win from the ventilator? So, at risk for failure to win. So, kanina nabanggit ko, at risk to fail to win kapag smoker, elderly, and usually pag may respiratory conditions. Those are the common risk factors. So, number 1, usually kapag high risk, pag ganyan, at risk, highest risk. So, kung possible na mag-count ng risk factors, try to count risk factors. So, in terms of age, number 1, it is a risk factor. So, smoker, another risk factor. May respiratory condition, another risk factor. So, may 3 risk factors in number 1. Si letter B, 37 in terms of age, hindi risk factor. Cardiac arrest, hindi naman respiratory condition. So, no risk factor. So, now, letter C, adult, so not an elderly, not a risk factor. Colectomy, so colon, no, wala naman, no? Walang risk factor. So, in terms of age, young, and then recovering from flail chest respiratory condition, 1 risk factor. So very good. Number 1 or letter A, highest risk factor. Kasi siya yung may tatlong risk factor. So kapag highest risk yung mga tanong sa inyo, if there's a possibility of counting risk factors, so that could be a technique. Number 10, after extubation of the patient, which finding would a nurse report immediately? Priority to report after extubation. What did you answer? Letter D. Bakit letter D? Crowing noise during inspiration. Ano ba ito? Stridor, very good. And as mentioned earlier, stridor is a sign of upper airway obstruction, laryngospasm. Emergency ba iyon? Is that an emergency? Definitely, right? So letter A, mataas ang respiratory rate post-extubation. Syempre, mag-a-adjust pa, no? And 25, not so high. Not an emergency. Hindi pa naman distress. Kung 30s na yan, so pwedeng sign of respiratory distress. Patient has difficulty sleeping, speaking. Expected lang, kakatanggal lang ng ET tube no? So may trauma pa. Oxygen sat 93%, medyo mababa, but not so low naman for it to be an emergency. So very good. Letter D is an emergency, laryngospasm, airway obstruction. Very good. So that could be a possible sign of failed extubation tayo. Pwedeng ma-reintubate yung patient, no? So letter number 11, the nurse has just finished assisting a healthcare provider with thoracentesis. So post-thoracentesis client with a recurrent pleural effusion caused by lung cancer. The thoracentesis removed 1,800 ml. So which patient assessment information is most important? Priority pa rin. So priority in terms of a post-thoracentesis client removed with 1.8 ml of fluid. Diagnosis is pleural effusion. So which is the priority to report? What did you answer? Anong sinagot nyo? Letter A, letter B, letter C, letter D. The patient starts crying and says she can't go on treatment with much longer. So more of psychosocial concern, no? So this would not be your priority. So physiologic versus psychosocial tayo. Letter B, patient reports sharp stabbing chest pain with every deep inspiration. Expected with the condition? Expected, not the priority. Letter C, the blood pressure is 100/48. Mababa. Heart rate is mataas. Hypo, tachy. What are you suspecting? So, madaming fluid na tinanggal. Oh, very good. Oh, possible sign of shock, right? So, could be a priority. Letter D, the dressing at the thoracentesis, 1 cm. Bloody drainage, 1 cm lang. Expected lang. Oo, no? Okay lang yon. So, di naman emergency. 1 cm lang. Okay? So, letter C, very good. This will be a more priority because this could be a warning sign of shock. A lot of fluid was removed, 1,800 ml. No? Okay. So, maraming fluid na tinanggal. kay patient. So fluid imbalance, risk for shock. So definitely letter C is their priority. Job well done. Number 12, which nursing action is highest priority for dislodgement of the chest tube? Dislodgement, natanggal sa patient's chest. What do we do? Cover the open chest wall, right? So letter C is the answer. Very good. So letter A, letter B, and letter D would not resolve the problem. No? So cover the open chest wall. 13, the nurse is caring for a hospitalized client with acute exacerbation of COPD. So which finding would the nurse expect to note? So expected for COPD. So related to COPD, select all that apply. Low arterial CO2, positive or negative. So expected ang hinahanap natin, we're looking for positive or expected for COPD. Expected ba ang low CO2? Negative, no? High CO2. There's retention of CO2, kaya nga risk for respiratory acidosis sila. Hyperinflated chest noted on the X-ray. Hyperinflation. There's impaired gas exchange. There's trapping of CO2, kaya hyperinflated ang lungs. Very good. Decreased O2 sat with mild exertion or mild exercise. Expected dyspnea on exertion. Very good. Unilateral chest expansion, meron ba yan sa COPD? No. Kanina noted yung unilateral chest expansion. Yung may increased pressure on one side. That is for unilateral chest expansion is for pneumothorax, no? Common for pneumothorax. Pulmonary function test, increase vital capacity. Increase vital capacity ba o decrease vital capacity? So poor gas exchange nga, so decreased. Okay, so answers B and C only. A, D, and E are all incorrect. So decreased vital capacity. So poor gas exchange. Very good. Number 14. The nurse is evaluating assessing a client with chronic emphysema. So click to specify if the action is correct or incorrect. So correct or incorrect lang for emphysema. High carb, low protein diet. Correct, incorrect? Incorrect. Bakit? Anong nagpamali? Baliktad, no? Should be low carb, high protein. So to decrease CO2 production. Okay, so very good. The instruct for sleep breathing. Correct, incorrect? Correct. Oh, okay, very good. Since there's trapping of CO2, so to blow off the excess CO2. How about elevate head of bed if difficulty of breathing occurs? Okay lang naman yun, walang problema. Frequently ask client using open-ended question. Open-ended. Kung gusto mong hingalin siya, why not? No? So that is incorrect. So dapat close-ended. We have to conserve their energy. So they easily get tired. Maintain O2 for 6 liters per minute. Incorrect. Okay, very good. So low flow O2 lang tayo so that they will not lose hypoxic drive. Very good. So magre-respiratory depression yung client mo kapag binigyan mo ng too much O2. Very good. So that is for number 14. The only correct ones are first lip breathing and elevate head of bed. Job well done. 15. Which assessment finding with a pneumonia? So in a client is with pneumonia, so sabi dito, which is the most important to communicate? Priority to report pa rin. So may pneumonia, priority to report. RR36, productive cough with rust-colored, sharp chest pain with deep inspiration, oral temperature 103. Okay, so si JRIRR, si Jaylan, IRR din. Bakit? Ay, si Jaylan ay letter B pala. Okay, and some is answering letter C. Iba-iba ang sagot nyo. Interesting. Okay, so walang sumagot ng letter B. Expected high-grade fever for pneumonia? Expected. Eliminate natin. Pneumonia ang case mo ha. Priority to report. So identify kung expected or sign of complication. Sharp chest pain with deep inspiration. Pleuritic chest pain. Is that expected for someone with pneumonia? Namamaga ang lang pa rin kay ma. Expected din. Okay? Productive cough na may rust-colored sputum. Expected sa pneumonia? Expected din. Ang pneumonia may takip niya. Pero bakit letter A is a priority to report? 36, sobrang taas ba ng 36? Kung 20s yan, expected lang. Kung 36 in respiratory distress na yan, Hindi to pedya ha, wala namang binanggit na pedya. So pag walang binanggit na age, so it is an adult. No, very good. So letter A is our priority in respiratory distress na yan, no? So 36 na, kung 20s pa, medyo expected lang, no? So but 30s na, in distress already. Okay, very good. So answer is letter A, B, C, and D are more expected. So next, number 16, tuberculosis, which indicates further teaching. Further. So further teaching, negative statement. What did you answer? Letter B. I will continue to take isoniazid until I'm feeling completely well. So sign of non-compliance, no? So kailangan tapusin yung gamot. Very good, 6 to 12 months. Everyone in my family needs to go and see the doctor for TB testing, positive or negative. Yes, no? So lahat itetest kasi may exposure sila. So kung mag-negative man sila, prophylactic drug pa rin sila. I will cover my mouth and nose when I sneeze and put used tissue in the paper into the plastic bag. So correct naman yon. I will change my diet to include more iron, protein, vitamin C. Good for wound healing. Ang vitamins, no, walang problema. So good for healing, di ba? And also boost immune system. Very good. So letter B definitely is negative, sign of non-compliance. So 6 to 12 months dapat tapusin kung as prescribed. 17, the nurse is admitting a patient to whom pulmonary embolus is ruled out. So pulmonary embolism ang pinag-uusapan natin. So the patient history and assessment reveals all which findings supports diagnosis of pulmonary embolism, which increases risk for pulmonary embolism among the history of the client. What did you answer? So hanap ka ng risk for? Okay, very good. So the patient with recent motor vehicular crash, so anything related to DVT, clot formation, thrombus formation, so that could be related to embolism. So letter A, patient participates in aerobic exercise, so active naman. Immobility, prolonged immobility, yun yung pwede, no? Or inactive, sedentary. So letter C, the patient gave birth a year ago pa, so hindi na yan risk for amniotic fluid embolism. Letter D, patient was on 6 hours lang naman, no? Hindi naman prolonged bed rest yon. So very good. Letter A is the highest risk. So may fracture involved kapag may motor vehicular accident. So pwedeng fat embolus, right? So letter A definitely is the highest risk. 18, left lung pneumothorax. So which would be your priority to watch out for? Priority. Anong sinagot niyo? Very good. So tracheal deviation towards the unaffected side. So letter C. So the rest are simply expected. No? So the chest pain, unilateral chest expansion, diminished breath sounds are all expected. But letter C is already a sign of complication. So in terms of prioritization, expected versus complication, complication is our priority. Number 19, prioritization in terms of patient. Who will you assess first? Who should you assess first? What did you answer? Letter D. Okay. Letter A, 68, ventilator, whom sterile sputum specimen must be sent to the laboratory. Priority ba si patient? Hindi naman, no? Kailangan sputum specimen collection lang. So, di naman urgent. Okay, stable patient. Letter B, COPD, pulse ox is 90%. Expected lang, stable patient. 72-year-old with pneumonia who needs to be started on antibiotic for treatment na versus kay letter D, si asthma daw may shortness of breath after using bronchodilator, unrelieved symptom. So letter D is our priority. May undue symptom even tapos nang mag-inhaler. Very good. Oo, okay. So letter D is our priority. So si letter C naman, for starting of treatment na, so stable naman yung patient natin kasi for treatment na nga siya. So last item, number 20, you are assigned 5 clients for the shift drag among the 5 clients you expect will not be indicated. Ang tanong, not indicated with CTT. Hindi kailangan ng CTT. Pleural effusion, kailangan ng CTT. May accumulation, so pang drainage. Yes, kailangan ng CTT. Lobectomy, post-lobectomy, kailangan ng CTT. Pang drain din, post-op, no? Pneumothorax, so may accumulation of air. So kailangan din ng CTT. Pneumonectomy, kailangan ng CTT. No, 'di ba? To allow consolidation to prevent tracheal deviation. Okay, very good. Hemothorax may drainage din, so kailangan ding i-drain 'yan. Puwede din bigyan ng CTT. Very good. So the only one not needing CTT is pneumonectomy. Okay, so answer here is pneumonectomy only. Sumobra? Okay. So yan, para lang din siyang select all that apply. Pwedeng isa, pwedeng more than one, or pwedeng all. Okay? So, kamusta ang inyong mga scores? Thank you as well for your active participation. Any questions, clarification before we end our session? Pasado naman, Great job, Teresa. Very good. Sige, before I leave with you, everyone, so I would like to remind you, okay, this one. Success all depends on the second letter, and that is you. So you are the one creating your success story. So no one could ever tell you that you are not capable of succeeding because ikaw lang mismo ang makakapaggawa ng success story mo. You are the one creating your own success story. So it's never impossible to succeed because you are the one making it. No one will make you successful aside from yourself. So everyone is capable of succeeding. So God bless you, everyone, and see you all tomorrow for immunology naman. Okay, so thank you so much. Have a great night ahead. And sorry for the overtime. Thank you, Sir Lauren.